Very good evening to all. I am Dr. Poonam Joshi, and I welcome you all on behalf of Department of Head Neck Surgical Oncology for our this TMC Postgraduate Teaching Webinar. This is our 5th year of this conference we are organizing. And this program, basically, initially when we planned, we thought that there were not many programs which were mainly for basic student teaching. So this program we have tried to keep very basic so that it can teach the student regarding the various case presentations, the operative techniques, and this will help them to prepare for the exams as well as will help in their day-to-day practice. With this, we start the program, and I request Pankaj sir, who is the director, and can I move it? Ashwini, I can move the screen. Yes. So I would request Pankaj Chaturvedi sir. Sir is Director, Tata Memorial Center, ACTREC. Sir is Professor, Department of Head Neck Surgical Oncology, and is Director, International Federation of Head Neck Oncology Societies. To please be there for the welcome address. Sir, you are there? So with this, I start the program. I would hand it over to Mansi, who is our HPNI fellow, and she has put a lot of hard work for this conference. Please, Mansi, come and we'll start the program.
Thank you, ma'am. Without any further ado, we will start with the first session of today, which will be on case presentation and discussion of early stage oral cavity carcinoma T1, T2, N0. So the expert panel for this session are Dr. Pankaj Chaturvedi. Sir is Director, Tata Memorial Center at ACTRAC, Professor for the Department of Head and Neck Surgery, and Director, International Federation of Head and Neck Oncologic Societies, IFNOS. Next, we have Dr. Krishna Kumar Thankappan. Sir is Professor and Head of the Department, Head and Neck Surgical Oncology at Amrita Institute of Medical Sciences and Research Center, Kochi. Dr. Mitali Dandekar, ma'am is Consultant Head and Neck Surgeon at Paras Cancer Center, Patna. And Dr. Nilesh Tiwari, sir is Consultant Head and Neck Surgical Oncology at LN Medical College and JK Super Speciality Hospital, Bhopal. This session will be moderated by Dr. Guru Kirti. Sir is Assistant Professor at the Department of Surgical Oncology, Adiyar Cancer Institute, Chennai. The presenter for this session is Dr. Katyayani Chaube. She is Surgical Oncology Resident at Tata Memorial Hospital. I hand over to Dr. Katyayani to present with her case discussion and presentation.
Katyayani, are you there?
Yes, sir.
Yeah,
So should I start?
Yeah, good evening all. I'm Dr. Guru Kirti, and at the offset, I want to thank whole organizing team, Track, and especially Poonam Madam for giving this opportunity to moderate this session. So we straight away start with the case presentation. The presenter is Dr. Katyani Chobe, surgical oncology resident TMH. Katyani, you can go ahead with the.
Very good evening to all. I'll be starting with my case. So this is a case of a 62-year gentleman from Mumbai who is a farmer who presented in our OPD with chief complaints of a non-healing ulcer on the inner aspect of left cheek from last 2 months. He was all right 2 months back when he noticed a non-healing ulcer on left side of cheek. 2 months back, it was initially around 0.5 centimeter in size and has increased progressively to the present size of around 2 centimeter. It is not associated with pain and he took some local medications but had no response. There is no history of any other lesion. There is no history of trauma or intervention. There is no history of pain in the ear. There is no history of decrease in the mouth opening, no history of any other swelling in mouth or neck, no history of bleeding. There is no history of any similar lesion or intervention in the past in the oral cavity. No patient is a known case of diabetes and hypertension and it is controlled on medications. There is no history of any surgery or history of dentures. Family history is unremarkable grossly. He takes tobacco in the form of quid, in which he uses tobacco leaves with slaked lime from last 20 years and keeps in the lower gingivo-buccal sulcus for around 2 to 3 hours and keeps it around 3 times a day. He is reformed since last 2 months. Bowel bladder habits are normal. Coming to the examination.
Katyan, you can stop. Examiners, do you want to ask any questions at this juncture?
Good evening, Dr. Katyan. Can you summarize the history again, please?
So this is history of a 62-year gentleman who is a known quid chewer from last 20 years with a non-healing ulcer in left cheek from last 2 months.
Can you go to the slide of presenting illness?
Yes, sir. Sir, this one?
Yeah. So why did you ask about history of pain in the ear?
Sir,
Or
since
such a small ulcer in the cheek?
Yes, sir. So it is around 2 centimeter, but I just wanted to rule out if there is any submucosal or a deeper extent of the lesion that may. It is not very common, sir. Just to rule out if there is any pain in the ear that the patient has.
What are the sites in oral cavity which will have referred pain? This is referred pain, right? So what are the sites in oral cavity which will cause a referred pain if primary is affected?
In oral cavity, pain may radiate from buccal mucosa, floor of mouth, anterior 2/3 of tongue, and also gingiva, sir.
Any part of buccal mucosa or specifically the lower alveolus or GBS?
So mostly from the GBS sulcus part, sir.
Right.
To the fifth nerve, it will radiate, sir.
More specifically, fifth is a broad term. More specific, which part of the fifth nerve?
Sir, third branch of the fifth nerve, sir, inferior alveolar nerve, and will radiate it, sir, all to the ear, sir.
And from tongue or floor of mouth?
Lingual
What's
nerve,
the efferent? Correct.
lingual nerve, sir, will radiate the pain to the ear, sir.
And what's the efferent? Just for completion, what's the efferent nerve of this referral arc?
So it radiates to the brain through fifth nerve, sir, and efferent fifth nerve, sir, will radiate.
That's the efferent. What's the efferent? How does patient feel pain in the ear?
Ninth to the ninth nerve, sir.
No, so it's auriculotemporal.
Auriculotemporal, sir. Seventh branch of seventh nerve, sir.
No, it's not seventh.
Fifth, sorry, sir.
Yeah.
So okay, sorry, sir. I got it. I got confused, sir. So the branches from the.
So for a referred pain, there is a efferent different branch, and efferent is another branch, right?
Yes. So the efferent is to the auricular temporal branch, which supplies the anterior anterior part of the external auditory canal, and the efferent is from the oral cavity, which is from the third part of the.
So point is that in early ulcers, malignant ulcers, you will not get this typical history of ear pain.
Yes, sir.
So if you go to the involvement of nerves, what other history you should try to elicit to if you want to rule out any particular involvement of the nerves, be it buccal mucosa or tongue?
If there is any area where he is feeling loss of pain or less sensation, sir, that may suggest a involvement of the nerve in that site.
Yes. What specific site it will happen in oral cavity?
So it will be around commissure, sir, if there is inferior alveolar nerve involvement, sir.
How it will happen in the commission?
The commissure is also supplied by the inferior alveolar nerve, sir. So there might be tingling sensation and less pain in this area if it is involved by the tumor, sir.
So you mean to say the local nerve endings?
Yes, sir.
And anterior GBS or lower alveolus, if it is involving mandibular canal, then what will be the complaint? That's very rarely patients elicit by themselves. You have to probe to find out whether that thing is involved or not. Can you tell what they will complain?
No, sir, this I don't know.
Loss of sensation with the mental nerve supply. Ma'am, sir, any other question in the history?
Hi, Katyani. Did you this case that you have displayed? I do not see any history of any dental intervention or no negative history of the same. Do you think it's required or it isn't required at all?
Ma'am, so I have taken the history of trauma or intervention that I have highlighted, ma'am. But because he's specifically complaining of cheek, ma'am, so I did not point out to the dental intervention, ma'am.
Complaining in the cheek as in? So where if he would have complained, would you consider that intervention important?
At the alveolus, ma'am, or in the lower or upper part of the mandible or maxillary sites, ma'am, or teeth, then I would have taken a history of dental. I have asked history, ma'am. There is no.
So any non-healing ulcer in the mouth, at least even if it is a negative history, make a mention that you have paid attention to the dentition of the patient. Any kind of repeated friction also could cause a dental traumatic ulcer on the cheek, and you by and large kind of rule out a differential diagnosis.
Okay.
So, yeah. I think I'm good. Can she go ahead, Dr. Nilesh?
Yeah.
Katyani, I have one or two questions.
Yeah.
KK here. Hi. So you were talking about the mouth opening.
Yes.
Why did you think of a mouth opening problem in such a case?
Since he has a history of 20 years of quit, sir,
Mhm.
I wanted to know if there is any oral submucosal fibrosis that the patient might be having.
Okay.
Uh,
So what are
and
the causes of trismus in related to oral cancer?
so oral cancers can present with trismus when there is involvement of the submucosa with the oral submucosal fibrosis,
Okay.
or when there is a temporomandibular joint. In advanced cases, when there is temporomandibular joint involvement of the or the muscles of mastication are involved, which will lead to a restriction of the mouth opening. Also, sir, if there is severe pain, the patient might not be able to open the mouth, and there may be a restriction in the mouth opening.
How should the pain cause restriction of mouth opening?
So, if there is a deep-seated lesion, sir, especially in the retromolar trigon, the patient may avoid the movement of the jaw so that the pain may not happen with each movement of the jaws.
Maybe.
Or-
Yeah. So pain can cause spasm of the,
Yes,
the
yes, sir. Due to that also, muscles and nerves are involved. Then also, sir, there may be restriction in the mouth opening, sir.
nerves are involved.
Sir, if there is any neurological compression or a pain that is radiating, the patient may have difficulty in mouth opening, sir.
Sorry, I think you're getting confused. The pain can cause spasm of the
Yeah.
muscles,
Hmm.
and that can restrict the mobility of the jaw. Clear, I
Okay.
think.
Yeah, yes, sir.
There's no nerve coming here.
Okay.
Pain can be caused due to neural involvement. What are the types of pain you know?
Neuropathic pain, visceral pain, sir.
And
Types of pain में तो sir grossly it is visceral pain and neuropathic pain, sir.
okay.
Can be sharp shooting types. It can be sharp shooting, dull aching. These are the types of pain.
Okay. I think you can read a little bit more about it. Can we go to the next slide?
Sure, sir.
Yes.
So you were talking about some family history. What sort of family history are you considering in this early oral tongue? Why did you consider that?
Sir, so there are genetic conditions which have familial involvement. Like they are not very common in Indian scenario, but just for the completion sake, I asked. It can be in cases of Lee-Fraumoni syndrome or dyskeratosis congenita or mm,
What is actinic keratosis?
actinic keratosis, in which the patient has a predisposition to squamous cell carcinomas in head and neck when exposed to sunlight, sir, because of P53 mutations.
What part of the oral cavity is more commonly affected, and why?
Sir, exact site I'm not aware.
Okay, what is it caused due to actinic keratosis?
Due to sunlight, sir.
So what part of the oral cavity can get exposed?
Mostly lip, sir. Lip is involved, sir, mostly.
Which lip?
Lower lip, sir, more than. Okay.
All right. Okay. Now coming to personal history. You're talking about some tobacco, right?
Yes, sir.
And slicket lime. Okay. And quid. What is a squid?
Squid in local language is known as khani, sir. So in this we use tobacco leaves which are dried, and it is mixed with slake lime and usually kept by the users in the lower gingiva buccal sulcus.
Why is it important? Why are you mentioning that here?
Sir, because the site of the placement of quid is related to the site of ulcer that this patient usually present with.
So is this patient presenting with the vestibular cancer? No.
No, sir. So it is not always associated with the same site, but most of the patients who have the habit of keeping quid, sir, may present with an ulcer in that site, sir. Also, it may lead. It is not just that it will affect the local site, sir. It can affect other parts of the oral cavity also, sir.
Affect means what? Why are you
Affect in the
mentioning that
form
history
of-
here?
Sorry, sir.
Why are you mentioning that history in this case? It is carcinogenic, right? The terminology
Yes, sir. Yes, sir.
carcinogenic.
Yeah.
Agree with me?
Yes, sir.
Okay, so how is it carcinogenic?
Okay, sir. So the tobacco in itself has around 70 carcinogens that has been identified.
Mhm.
And of these, the most common ones that are implicated are benzenes, polycyclic aromatic hydrocarbons,
Mhm.
and these, when used with slake lime, have increased. Slake lime will decrease the pH and will increase the penetration of the carcinogens into the cell, and which will form.
Is it decreased pH or increased pH?
So it decreases pH, sir.
That means it makes it acidic, is it?
Yes, sir.
Sure.
Yes, sir. Yes, sir. I'm sure, sir.
Okay. I thought it is otherwise. Maybe somebody can correct me if I'm wrong.
Lime makes it alkaline, I guess.
Yeah. So you are absolutely right. So
Yeah.
what happens that if you look at tobacco or areca nut, in both cases, the alkaline pH leads to higher extraction of alkaloids as well as nicotine in case of tobacco, gram by gram. That means if you are taking X gram of tobacco, then if you want higher extraction of nicotine, make the pH alkaline, saliva alkaline. And that is why traditionally it is taken with lime so that you get more pleasure out of having the tobacco. But what happens that even carcinogen exposure increases, and therefore slake lime may be giving pleasure, but at the same time, it adds to the carcinogenic potential and addictive potential of both areca nut as well as the tobacco.
Yes, sir. Yeah.
Yes.
Kenny, I think you got it clear.
Yes, sir.
Katyani, what's the relative risk for from the tobacco for the oral cancer?
Sir, the risk associated with tobacco.
Smokeless tobacco, I'll be specific. Is it same for smokeless tobacco or cigarette smoking for oral cancer?
No, oral cavity is more associated with cancer if it is smokeless form.
What's
And,
do you know
and,
the risk, the relative risk?
It is around, sir, according to the study by Mashiba, it was over odds ratio is around 2, sir. If tobacco is taken.
It may be different for different populations because the habits are different. It's usually above 3 for Indian population.
Okay, can we come to the next slide? Okay, are you done? You're done. So from the history, Katyani, what do you think? What is happening in this gentleman?
In background of 2 months of a non-healing ulcer in a patient who of a middle age who takes tobacco from last 20 years it is more suggesting to a malignancy, sir. However, I like to confirm it with examinations.
So why do you say it is malignancy? And what is the cause for the malignancy?
A malignancy because it is more than 3 weeks of a non-healing ulcer.
Okay.
And patient has a addiction of tobacco.
And is it progressing in size?
It has increased with a progressive increase in size, and also it is painless, sir.
Okay.
So these factors suggest more in the favor of malignancy, sir.
And what is the probable etiology in this case?
Tobacco with slake lime is
which is a carcinogen.
Yes,
Okay.
sir.
Okay. I think You have done fairly well. Nice. Next.
Yeah, since you have completed we can start with the examination.
Yes, sir. So this patient was examined in a well-lit room after informed consent and is moderately built with well-nourished. He was conscious, oriented, and vitally stable with ECOG performance status of 1. There was no pallor icterus, cyanosis clubbing, or generalized lymphadenopathy.
Katyani, just wait for a second. Did you say informed consent for examination?
Yes, sir.
Do you do it? Informed consent for examination.
So I will ask the patient that sir, this is in the form, like I'll be just explaining to the patient that I will be examining him and if he is okay with it.
Okay. All right. Now go
So,
ahead.
Katyani,
Sir.
so this is not called informed consent, because when a patient enters the hospital, you take a general informed consent form for all investigation. So you must say that I inform the patient that this is what I'm going to do. But if you use the word informed consent, it is not the correct word to be used for this. Okay? Informed consent means that you asked him to sign a document after explaining him that I'm ready to undergo examination. You understand?
Yes, sir.
So when you, and similarly you said in a well-lit room. Now you should not in an exam say that, well-lit room or informed consent. These are not very, like for MCH, they may not be considered appropriate. Okay?
Yes, sir.
Whatever you do, you can tell. You need not cook up things. Okay. Yeah. Go ahead.
Yes, sir.
Go ahead.
Sir, so on local examination, the face looks grossly symmetrical. Mouth opening is adequate. Oral hygiene is poor, and there is tobacco staining present in the upper and the lower teeth. Halitosis is present, that he is partially edentulous, and there is loss of upper incisors and lower bilateral premolar, sir. On examination, there is 1 into 1.5 centimeter lesion, proliferative lesion in the left buccal mucosa, extending 3 centimeter from oral commissure, 1 centimeter anterior to the retromolar trigone, just below the second molars, and upper and lower gingiva buccal sulcus appears free. It is oval in shape with irregular margins and surface appears uneven. There are also 2 nicotinic patches just anterior to the lesion, which is around 0.5 into 0.5 centimeter with smooth surface. There is a mottled appearing of the surrounding buccal mucosa, especially in the posterior aspect. Rest of the buccal mucosa appears normal. There is no leukoplakic or erythroplakic patch. Tongue appears normal with no restriction of movement. Hard palate, soft palate, uvula, pharyngeal walls appear normal. Parotid duct opening can be visualized and is normal. There is no visible scar, sinus, or fistula. On palpation, the findings of inspections are confirmed. There is no tenderness, low local rise of temperature. 1 into 1.5 centimeter firm, hard, non-tender proliferative lesion is noted in the buccal mucosa with surrounding induration. Mucosa appears mottled and has a vertical band at the RMT. Skin is not involved. Floor of mouth, tongue are unremarkable. There is no palpable lymphadenopathy and Hopkins were grossly normal. Systemic examination was grossly unremarkable, sir.
You can stop it here. What is adequate mouth opening, Katyani? Can you just tell?
So if the mouth opening is around 3 fingers of the patient like he can put 3 fingers in between the incisors, it's adequate mouth opening, sir, which is around 3.5 centimeter or more.
Is it a correct way to convey this, or is there any scaling you know of?
So interincisal distance more than 3.5 centimeters, sir.
What is that grading system known as?
What is the, sorry, sir?
Grading. What is the name of that grade?
So
it is mentioned in the Khanna and Arcade grading, sir. That was published in 1990.
Good.
Yeah.
So you should mention the distance exactly. Just simple measuring by the ruler.
So I used his 3 fingers and it was around 3.5
And
centimeters.
do you want to comment on submucous fibrosis?
Yes, sir. They were mottling of the mucosa, as can be seen in the picture also, sir, especially in the posterior aspect, sir. Around
Is it
the
there or not? Is it there? Submucous fibrosis is there? Was there in
yes,
the
sir.
patient?
It is there, sir. Here also, sir, it can be mucosa appears mottled, sir. So a grade.
What is the grade? What are the grades or degrees of submucous fibrosis?
So according to the Khanna and Arcade grouping, sir, there are 4 groups, 5 groups. The first group is the first group is when there is no restriction in the mouth opening, and there is only stomatitis or ulceration that the patient has. In the group 2, which is the early group, there is a decrease
So
in the mouth
why the
opening.
submucous fibrosis is significant? How does it change your management or planning of the further treatment of the patient? How does it change?
Sir, so access to the lesion, first of all, can be difficult if there is significant oral submucosal fibrosis. Also, it can be it is a pre-malignant lesion, sir, potentially malignant lesion. So the other parts of the mucosa can also turn into malignancy. So
Are you going to remove all the some fibrotic patches?
no, sir. So just that it is a potentially malignant condition, and
Any effect on prognosis?
prognosis, yes, sir. The prognosis of the patient will be not very good if the patient has a underlying oral submucosal fibrosis.
How can you back up with any literature for what you just said? Is there any study showing that?
I'm not aware, sir. I have just I am aware of
not.
Sorry.
No, it's not that. It does not cause poor prognosis. In fact, it is some studies have shown that submucous fibrosis may be a positive role in preventing regional metastasis.
So that was seen in a study from TMH, sir, because the vascular thing, the underlying vasculature is also decreased in OSMF, sir. So
just read a bit about fibrosis, for
okay,
example.
Sir. Yes, sir.
So Katyani, I will quickly tell you. So what happens that patients who are having submucous fibrosis, they are symptomatic and they consult the doctors more often than the patient who have painless ulcer. And that is why the early detection and then fibrosis of the submucous fibrosis layer, which leads to strangulation of the lymphatics, leading to delay in the lymph node metastasis also. And that is why they have better prognosis.
Okay, sir. Yes.
So,
Okay, sir. Yeah.
Katyani, what is this RMT you're talking about?
It is the retromolar trigone area that is just behind the third molar. It is a pyramidal shaped area extending from the in the just behind the third molar, with the base at the mandible and apex formed by the apex reaching just behind the maxilla, sir.
Correct. Why is it important?
So if lesion is reaching there, sir, we will need to resect the upper alveolus also for margins also, there is a propensity of nerve invasion because the underlying nerves are close to that area, madam.
What underlying nerves are you
So,
concerned?
so inferior alveolar nerve is there, sir,
Mhm.
just at the RMT, sir. So it can also, the lesion, if extends into the RMT, it can reach up to the posterior pharyngeal areas also, sir, through the nerve.
Locally spread. You told about inferior. What other nerve is more close in our
Mandible,
in our
mandible,
mandibular nerve? Other than that,
lingual nerve, sir.
lingual nerve. Where does lingual nerve come?
Lingual nerve will come just the
What is lingual nerve a branch of?
fifth, fifth nerve, sir. The third branch of fifth nerve.
Okay, comes down just
Uh,
medial to the RMT, right?
yes, sir, and then goes into the tongue, sir, through that area.
Okay, what is pterygomandibular raphe?
Pterygomandibular raphe is the raphe extending from the mandible, and it forms the posterior boundary of the RMT, sir, extending from the
Where is it
pterygoid
attached? What
hamulus.
are the attachments?
Sir, it attaches to the pterygoid hamulus to the mandible, sir.
Yeah, anteriorly it attaches to the buccinator and inferiorly to the mylohyoid loin of the mandible. Okay, so what is the importance of the lingual nerves, inferior alveolar nerve and pterygomandibular raphe in relation to, the RMT and your relation close to it?
Sir, so if these areas are involved and there is a tracking down of the lesion through this nerve, for taking margin of these nerve,
Tracking to where? Tracking,
tracking,
where does it track?
tracking to the base of the skull, sir. It will track to the upper in base of the
Are there any spaces in between the skull and the RMT where these structures travel? What is
pterygomandibular fissure and through it.
pterygomandibular fissure or pterygomaxillary fissure?
Maxillary fissure. Yes, sir.
And one fossa?
Uh,
One fossa which is
Pterygopalatine fossa, sir.
pterygopalatine fossa. Okay. So the thing is that if there is a advanced tumor, not like this tumor, maybe it can spread through the nerves and it can affect pterygopalatine fossa. And once it reaches the pterygopalatine fossa, it is like a crossroad. It's a junction, and from there it can travel to multiple areas. So that is the importance of RMT, the nerve, pterygomandibular raphe, and so on. Yeah, Pankaj sir, please continue.
So can we just quickly go on to the next slide? We have left with another 10 minutes.
Okay, that's okay.
Yeah, Katyani, continue.
So, summarizing my case, this is a 62-year gentleman with a proliferative growth of around 1 into 1.5 centimeter in left buccal mucosa with tobacco addiction with grade 2 OSM, oral submucosal fibrosis, sir. So, clinically, it looks to me as a case of buccal mucosa, carcinoma buccal mucosa, T1, N0, M0 stage 1, sir.
So Dr. Katyani, one comment. In palpation, you should try to mention about thickness of the lesion. As we are running short of time, so for further discussions, just remember, try to comment on thickness of the lesion and skin overlying the lesion. We have simply written skin is involved. So you should mention specifically skin overlying the lesion is not appearing puckered or involved.
Yes, sir.
Right?
Yes.
Okay, you can go ahead. And if any other question?
Katyani, what is your Mitali? You have some questions?
Yeah, so Katyani, exactly, I wanted to endorse what Dr. Nilesh said. Even in your summary, it's good that if you give a three-dimensional assessment of the lesion rather than just two-dimensional. It looks highly inadequate, after the stage of CC8 to just call it stage 1 by giving us only two-dimensional. this is a gross inadequacy. Yeah.
Okay, ma'am. Yeah, ma'am. I noted, ma'am.
So
Okay,
how would you then? Okay, sorry. Go ahead.
Go ahead. No?
Please continue, ma'am. Please continue. Yeah.
So, Katyani, then how then in order to complete this summary, how would you assess the depth?
Ma'am, for assessment of depth, we'll do an investigation, ma'am. So it will be
Just tell us first how till the time you reach a summary, right? You will have to tell us how you assess quickly. So then we move on to the next part of investigation and treatment.
by palpation,
With a
ma'am. Clinically, we can palpate the lesion and know the depth of invasion, ma'am. Also, we can figure out the extent of the lesion from the whole of the growth and
palpation, it would be appropriate if you use bimanual palpation, right?
yeah, yes, ma'am. So
yeah,
we'll
yeah.
clinically palpate it using our fingers outside and inside, and we'll know the depth of invasion from the
Approximate depth.
Yes, ma'am.
Yeah. Okay. So let's continue. Let's move on to the next.
So how will you evaluate this case?
Sorry, sir.
How will you investigate and evaluate this case?
So to confirm my diagnosis, I'd like to go ahead with a biopsy of this lesion, sir.
What type of biopsy? What type of biopsies you know, and which one you will use in this patient?
So I'd like to take a punch biopsy from the most representative area of the lesion, sir.
Any advantage of incision biopsy?
Incision biopsy will avoid the crushing of the lesion that may happen with the punch biopsy, sir.
Well, I'll rephrase. In which cases you will go for an incision biopsy rather than punch biopsy?
So the lesion that infiltrates, sir, or where the punch biopsy forceps will not be able to hold the lesion, sir, we'll like to go ahead with the incision biopsy, sir.
Yeah, in cases of submucosal lesions, indurated lesions, or a very verrucous looking lesions in which you have to get subepithelium. Right. So after punch biopsy, what next?
So I'll also like to stage my patient because it is suspected carcinoma buccal mucosa. So I'd like to stage this patient with a contrast enhanced CT scan of head, neck, and thorax.
Why are you preferring CT scan? Are there any other modalities that can be done?
So it has been seen in multiple meta-analyses that CT scan has highest sensitivity, sir, and it is a one-stop investigation that will help with the planning and also with the neck nodes and also the staging of the thorax, sir.
Okay. So what are you concerned here in this lesion? As this imaging is concerned, what exactly will you look for in this lesion?
So I like.
Do we have the scans?
Yes, sir.
Okay, can you go through it?
Sure, sir.
So what is this? What are you seeing?
Sir, so this is a contrast enhanced axial cut of a head neck. Sir, so I'm concerned as of now for my local extent of the lesion, in any infiltration into the deeper aspect that I may not be able to palpate, or any other lesion that this patient may have. Also, involvement of the underlying muscles or buccinator muscle and extension of the disease that may not be palpable, sir. So grossly over here, if you can see the pointer, sir, there is a hyper enhancement of the gingival buccal mucosa, sir.
Right. Katyani, let me ask, you are talking about this axial CT scans, right? Is it contrast or non-contrast?
This contrast, sir. Contrast enhanced.
How do you identify that quickly?
So that we will see the vessels, sir, if they are enhancing, and
Very-
if they have contrast, sir,
very
it will suggest a
Can you
contrast.
just show me the, coronoid process of the mandible?
Yes, sir. So this
Okay.
is the coronoid process of the mandible.
Okay. Why do you say it's coronoid? I mean,
Anterior, it is anteriorly placed, sir, and posteriorly we can see the coracoid process, and
Wonder-
then we'll see the sigmoid nerve.
okay, and which is a medial pterygoid muscle?
Yes, sir. So this is the medial pterygoid muscle, sir, and
Correct. Correct.
upper
And
sigmoid.
yeah, you're right. You're right. Well, I mean, what particular or maneuver they have employed to help you to see this lesion better in
So
this case?
the cheek maneuver is done in this CT scan, sir.
Correct. How does it help?
Sir, so this will help in uh, highlighting the vestibule or the gingivobuccal sulcus of the lesion, which would be otherwise collapsed in a normal patient, and the lesion in the gingivobuccal sulcus and its relation to the surrounding mandible cannot be better appreciated, sir.
Correct. Correct. So
That's
now
why.
show us the lesion quickly.
Sure, sir. Um, yes, sir. So this is the hyper and sorry, sir.
No worries. What else will you specifically look for in this case?
So the underlying muscle involvement, extension of the disease, and also if there is any
Is it close to the bone?
no, it does not look any close to the bone, sir.
Okay, so
This
bone is far away. And in the neck?
next, sir, we look for any lymph nodes on the same side, and also on the contralateral side, sir. And yes.
Right. So you do. What is your clinical? I mean, staging after your imaging?
It remains the same clinical radiologically T1 N0, sir. M0.
Okay. Mithali or Pankaj sir, please.
Dr. Katyani, there's a question from Dr. Rajdeep sir. Will you do biopsy before or after imaging? Is there any relevance or is it just arbitrary?
Sir, so biopsy can be done, sir, at the outset in this patient, sir. In the lesions of tongue, we usually prefer to do imaging first, because biopsy may lead to the
How it will affect your appearance, the appearance of the lesion on image? Will biopsy change it?
yes, sir. The exact extent may be modified because of the increased vascularity post biopsy, sir. But most of these lesions may not get affected when we are doing a biopsy of buccal mucosa, sir. Tongue lesions are seen to have some changes post biopsy, sir.
Yeah, if the gap between biopsy and imaging is not significant, then it doesn't matter. But sometimes even after biopsy, because of the inflammation, there will be edema, peritumoral edema, which you cannot correctly attribute whether it's because of biopsy or the disease itself. Right? And you rightly said in tongue, it will make more changes.
Okay. So how are you going to? So you'll take a biopsy. You will take a CT scan, and then how are you going to treat this case?
So I'll like to go ahead with excision of this lesion, sir. And since the underlying muscle does not seem to be involved, the base can be formed by the muscle, sir, with a margin of gross margin of around 1 centimeter all around.
Which muscle are you talking about?
Buccinator, sir.
Buccinator muscle. So how will you take it out?
Sir,
You want
around
to
1
take it,
centimeter.
you are saying you are going to take it out with 1 centimeter margins, right?
Yes, sir.
Okay, so how are you going to do it?
With 1 centimeter margin, we'll take it out with the muscle as the base, sir.
I know what you get, but how? What is the approach?
Approach is per oral approach, sir. I can access this since the patient does not have any restriction in the mouth opening. The lesion looks well approachable by the per oral approach, sir.
Okay, and how will you assess the depth of the adequacy of margins in the depth intraoperatively?
So it can be done by the surgeon, sir. That the depth of the invasion and adjust at the base of the lesion. If there is around a margin of around 7 mm, it would be taken as adequate, sir.
So
Also, if the muscle
you
is
will measure intraoperatively 7 mm. How are you going to do it? How will you assess the depth and get it out?
so that will be by palpation only, sir. We can take that.
So how are you saying 7 mm? What is the practicality there?
So it has been seen that if the margin has been taken around
No,
7.
I agree that I know what you're talking about, the 7 mm. But my question is, how will you assess it?
So by palpation, if
By
there is.
palpation. Now,
Yes.
yeah, with your hand. Right, you will assess the three-dimensional with your fingers and probably, and then to confirm, you may do something. What can you do after taking the lesion out?
So I can send the specimen for a frozen section, sir.
Right.
If the facility is available at my center.
Okay. Yes. Right.
So, Katyani, does the location of this T1 stage, so do all stage 1 buccal mucosa cancers mandate per oral approach? As in, are all T1 or stage 1 buccal mucosa cancers amenable to per oral approach?
No, ma'am. No.
So which are the ones you would not do via the per oral approach? What are the um, concerns? Which all kind of stage 1 cancers will you not approach per orally?
So in this case, what is the difficulty you will have if you go per orally? That's indirectly my man.
So if there is a lesion that is posteriorly located, ma'am.
Okay, location 1, perfect. Second.
Also, if there is restriction in the mouth opening, there will be.
Predisposing, yes, which will come in the way of adequate margins. Third.
Third, also, if there is a doubt of the posterior margin, ma'am, with the surrounding structure, we'll like to take a flap and then reach to the lesion and take it out with the surrounding structure.
Yes, if it is close to the mandible,
yes.
Upper, lower alveolus, or the RMT. Yeah.
Yes,
so
yes,
these three things are appropriate. And another thing, so what are the other approaches? If not per oral, what are typically the other approaches you would utilize to access posteriorly based?
So we can raise flap, ma'am, through a midline split, ma'am, and we can reach the lesion by elevating a flap and reaching the lesion through a midline lip split.
Always a midline lip split? When did you take
no, we prefer midline lip split, ma'am. It can also be angle split.
When do you access via angle split?
Is it based on preference, or there is a logic when you choose a midline, when you choose an angle split?
No, sir. There is a logic that the upper and lower labial arteries, if there is a chance of, especially if the lesion is close to the commissure, sir. The lesion is close to the commissure, then the angle may lose blood supply. So we in these cases we prefer a angle split, and if the lesion is not close to the commissure, we will prefer the midline split, sir. Because the labial arteries anatomy is such that it will go in the upper part and lower part, and will be sacrificed if we go for a lip split for a commissure lesion, sir.
Do we have time, or have we, Dr. Poonam?
Yes, Mitali, I think we can wrap up. We can just, you can
Yeah.
give the marks to her. Yeah.
Yeah. So, Katyani, I think you're well prepared, but yeah, I mean, there can still be some more reading that can be applied, but well done.
Yeah, you did well. Just
Wish you
a
all the
bit
best.
fumble here and there, but good.
Yes, Katyani, I think you did fairly well. Need some more reading, but all the best for your further preparations.
All the best.
Thank you, sir.
Thank you. I think we can conclude, Poonam.
Thank you, moderators and the expert panel, for this enlightening discussion. Moving on to the next session. So moving on to the second session for today. The session will be on operative technique discussion on marginal mandibulectomy. The expert panel for this session are Dr. Anuja Deshmukh. Ma'am is professor in the Department of Head and Neck Surgical Oncology at Tata Memorial Hospital, Mumbai. Dr. Dushyant Mandlik. Sir is surgical oncologist, head and neck, robotics and reconstructive surgeon at HCG Cancer Center, Ahmedabad. Dr. Abhishek Vaidya. Sir is head and neck senior consultant oncosurgeon at National Cancer Institute, Nagpur.
Hello.
Dr. Rajdeep Guha. Sir is consultant head and neck oncosurgeon at Chittaranjan National Cancer Institute, Rajarhat, West Bengal. The presenter for this session is going to be Dr. Vidisha Tuljapurkar. Ma'am is associate professor in the Department of Head and Neck Surgical Oncology at Tata Memorial Hospital, Mumbai. I request ma'am to kindly start sharing the screen.
Okay, it's showing that other participant is sharing. I cannot share the screen. Can you please correct that, Mansi?
Yes, ma'am. I have just stopped sharing. Can you try again once, ma'am?
Yeah, just a second. So, hello everyone. We have a very senior panel today for our discussion. So, I request all of them to please chip in at any point of time while the discussion is going on for the benefit of all our residents. Is my screen visible, Mansi? Hello?
Yes, ma'am. It is still on. You'll have to select.
I will just do that. Give a second. Yeah, is it visible now?
Yes, ma'am.
Yeah, so hello everyone. Hello, Dr. Dushyant, Dr. Anuja, Dr. Abhishek, and Dr. Rajdeep. So we are to discuss just operative technique of marginal mandibulectomy. I think we had planned that we will discuss the same amongst the following points. That is pathways of tumor spread. How do we select a case? How do we plan an incision for the same? What are the surgical tips and tricks while doing the same surgery? What kind of reconstruction we use when we have performed a marginal mandibulectomy? What are the complications and how do we rehabilitate these patients? Okay, so marginal mandibulectomy, as we all know, is a surgery where we remove mandible either as a part of margin where the tumor is abutting mandible from either the cheek or the ventral surface of the mouth or tongue, or for a superficial alveolar erosion. This is a very famous article which all of you all students must know about how the tumor spreads to the mandible. So I would like to start from there. So can I have Dr. Anuja ma'am to please tell us about various ways in which the tumor spreads to mandible and what are the most important ones that matter in these cases?
Thank you, Vidisha, for providing the slide, which actually states there are 7 ways of tumor infiltration. So you can read about this all 7 approaches, how the tumor gets into the mandible. But the most important thing you have to remember how we reach this all routes of invasion into the mandible. So initially it was thought it is the periosteum which is a problem and you need to remove it for every case. And then we reach the concept of a point of abutment theory, which is the most important theory nowadays, which we follow. So it is not always the occlusive surface from where the tumor gets into the mandible, but that is the commonest site. But the most important thing is the point of abutment that we have to remember. And depending on the point of abutment, we decide whether we have to do a marginal or we have to do a segmental mandibulectomy for the patient.
Right. Thank you, ma'am. Dr. Abhishek, apart from this point of abutment, any other factors that we would like to take into consideration when assessing a case, whether it is suitable for doing a marginal mandibulectomy or it should go for a segmental? We would like to elaborate upon that.
Yes. Two important factors. Is there any soft tissue disease on the lingual or the buccal of the mandible, which is known as paramandibular disease? Second is patients, and third, a relative contraindication would be as the patient with prior radiotherapy. So prior radiotherapy, dentate versus edentulous status, and soft tissue which is involving the lingual or the buccal cortex of the mandible. Abutting the lingual or the buccal cortex of the mandible, so-called paramandibular disease.
Right. So the most important thing, like you said, sir, is vertical extent, height of the residual mandible, extent of paramandibular disease, which is a very clinically important decision to be made by the surgeon, and also the horizontal spread of the disease, how far away the tumor is from your mandible. Right. So, Dr. Rajdeep, do we have him here? Hello?
Yeah, I'm there.
Yeah. So, sir, could you please tell us about different types of mandibulectomies, which are the common types of marginal mandibulectomies done and which are a little uncommon ones?
Okay, so the most common marginal mandibulectomy that we come across is where we are removing the margin close to the tooth, the upper part of the mandible. Now, this can be from where the coronoid starts to where we need to remove, like the entire extent. It can be in the anterior, it can be in the lateral part of the mandible. There are the other types, like we have the oblique and the vertical ones. Now, the vertical one, there is also a paper by the Tata group about the outer part of the mandible being removed, and we have the lingual plate of the mandible being removed. Sometimes, rarely, we will also need to do a rim resection of the mandible from the inferior end when the nodes are stuck to the mandible.
Right. That we would call it as a reverse marginal mandibulectomy.
Reverse marginal mandibulectomy.
Right, sir. So my question in general to every one of you, we do all horizontal marginal mandibulectomy very frequently, but how do you go about deciding feasibility of doing a oblique or a lingual plate marginal mandibulectomy? Any clinical pointers to decide about that? So how do we decide whether a candidate is suitable? Yeah, please.
Hello.
Yes. Please
Yeah,
go ahead,
Dr. Dushyant here.
Yes, sir. Please go ahead.
So Vidisha, that basically the decision of your marginal mandibulectomy comes when there is a cortical erosion of your bone. Now, when you are thinking of an horizontal marginal mandibulectomy, usually it's an alveolar disease which is sitting on inner and outer side of the bone, which is the lingual side as well as the buccal side of the bone. At that point of time, you want to have margins on both the sides, where you go for an horizontal marginal mandibulectomy. You can do a slightly oblique marginal mandibulectomy when the disease is at either of the side. If it is at the inner side, you take more bone on that side. The idea is to keep more bone stock, sturdy bone stock, to make your marginal mandibulectomy stable. Equally, same, the vertical marginal mandibulectomy is usually used for a limited disease of floor mouth, which is abutting or coming near to the inner cortex of your mandible.
Right. So I'd like Anuja ask Anuja madam, how do we decide between whether we need to do a marginal mandibulectomy, or we can just away with removing the gingival mucosa, which is commonly called as mucoperiosteal stripping? How do we decide upon that, whether a marginal mandibulectomy is required for a buccal mucosa disease, or we can get away without doing it?
So why we do a marginal mandibulectomy is because the tumor is approaching the mandible. So it is close to the mandible, or it is reaching the mandible, or superficially involving the mandible. And in this situation, you will again the line of abutment you will evaluate. So you will do when the tumor is far away from the mandible and you can get an adequate margin on the mandible, then you can just do a periosteal stripping. But if the tumor is abutting or coming very close to the mandible, you will require some kind of a mandibular resection so as to get that medial margin adequate for your resection. There you will do a marginal mandibulectomy. So tumor approaching to the mandible or very close to the mandible where you cannot achieve an adequate margin, there you will do a marginal mandibulectomy. If you have adequate margin with mucoperiosteal stripping and line of abutment tells you that you are very far off and you can take care of all the soft tissue in all 3 dimensions, please go ahead and do the mucoperiosteal stripping. Then you will not require a marginal mandibulectomy.
Right. Thank you, ma'am. So now that we have established the ways of tumor spreading to mandible and what is the line of abutment, what are different types of marginal mandibulectomy, my next point here is how do we assess the radiological spread of the tumor for suitability for marginal? So Dr. Abhishek sir, can you please tell us about different modalities which are available for assessing adequacy for marginal, whether CT, MR, any other modalities, and which is the best?
Vidisha, can I just tell something about this vertical and oblique? Just a
Yes,
point about.
Please,
you
ma'am.
can just go to that slide.
Yes, please, ma'am.
So the thing is, the rim marginal mandibulectomy is the most commonly performed, and all the retrospective data about the control, survival, everything about the rim marginal mandibulectomy. You do a oblique or a vertical for a limited disease and mainly for the floor of mouth because you wanted to take care of the disease which is coming closer to the mylohyoid muscle and abutting. That's why you do a oblique marginal, taking a lingual plate. Doing a vertical marginal or oblique, you actually take care of a major part of the mandibular bone. But said that the inferior part of the mandible is most strongest, as we know from the cadaveric data, and the more 50% of the cross sectional of the mandible is in the inferior cortex. That's why you leave behind the most important part of the bone with the patient so that you don't have a pathological fracture. Other thing is all the accessory foramens are there in the upper part of the mandible and very less on the lower part. So the route of entries you are taken care when you are removing the upper part of the rim of the mandible. So that is the whole idea why we do a marginal mandibulectomy and different types and all that.
Right. Thank you, ma'am. Yeah. So coming now to the radiology, Dr. Abhishek, could you please give us some pointers about which modality to choose and which is better to assess spread involvement of bone by the tumor?
So contrast CT is the modality we call from the tongue, and the bone cuts of the CT scan will also tell you about the involvement of the bone. Now, which in particular you can have an oblique reconstruction, and which will tell you about the exact extent of bone erosion. You can also do a 3D recon and then rotate the image as you want, and then calculate the depth of erosion. Now of interest, if you are contemplating marginal mandibulectomy in superficial bony erosion, then remember that there should be enough remnant bone.
I think we lost the
Yeah,
voice
even I
from-
cannot hear. Yeah, even I cannot hear. Maybe there is some connectivity issue. Or Dr. Abhishek, can you hear us?
Yeah. Sorry, I got disconnected. Can you hear me now?
Yes, please. Thank you.
Can you hear me now?
Yes.
Yes,
Maybe
sir.
the connection
Yeah.
is really lagging.
So, yeah, I'm sorry. Take into account three things. One, the remnant height of the mandible should be enough to account for 1 centimeter of margin, 1 centimeter of remnant bone, and maybe 1 or 2 millimeter of bone loss while you're cutting it.
Right. So, as rightly said by Dr. Abhishek, CT scan, a multi-detector CT scan with oblique reformatting is one of the best modalities that you can have for assessment of buccal mucosa lesions going on to the mandible. For the benefit of students, they should know this article in which multiple modalities were compared to assess the efficacy for involvement of the tumor, which is OPG, MDCT, DENTA scan. And this study found that MDCT was the most accurate imaging modality to decide about the involvement of the mandible, right? So again, now we come back to our indications and contraindications. The absolute contraindications will be gross mandibular erosion, paramandibular. Hello?
Vidisha, can I just interrupt you, please?
Yes, ma'am.
So the previous study, what you have shown in that, there is no MRI, right?
No, there is none, ma'am, because those were for a buccal mucosa cancers where we would usually do a CT scan.
Yeah, so the thing is, if you look at the bony involvement, the MRI is also a good modality where you have a high specificity and sensitivity, what you have it in the CT scan. The most advantage what you get with the CT scan is more specific. With MRI, what happens that the medullary edema can actually give you false positive result when you do a MRI. So MRI can give you a high result, but it has to be cautiously read and it takes longer time and other things. And the CT scan is friendly with the surgeons to read about and shorter time also. So those are the advantage. If you have a floor of mouth disease, then I will do a MRI. I will not look at the CT scan. Maybe if I have a choice of only investigation.
Right,
And when
point
it's the
taken, ma'am.
erosion, then I will do a MRI maybe.
Point taken, ma'am. Completely taken. So
Also,
this is to
if the
summarize. Yeah,
if the
please.
tumor is close to where the mandibular nerve is exiting, then this is one point where I would want specifically to get an MRI done to look if the tumor is invading via the mandibular nerve opening into the marrow of the bone. Even if on CT it may not show a bony cortical erosion. So on specifically if tumors near the mandibular foramina, I would want an MRI.
Right. Very good point, Dr. Rajdeep. Thank you.
Also, Vidisha, I think in the patient who are partially edentulous, that is also possible in our set of patients where there is a poor dental hygiene, to be a little extra cautious. As it is rightly mentioned, we would like to get an MRI done, though it may overestimate, but it will save us from a lot of problems intraoperatively.
Right, exactly. So now that we have gone through the indications and assessment of the patient for marginal mandibulectomy, let's come to the surgical tips and tricks. So I'd like to ask Dr. Dushyant, what would be your incision planning for performing a mandibulectomy? How would you decide about which incision to place, per oral versus cheek flap? Which kind of incision? Can you give us some pointers?
So Vidisha, basically it will depend upon on which part of the mandible you are going to perform your marginal mandibulectomy. If the mouth opening is good, that is, there is no submucous fibrosis. If the resection is anterior, let us say central large tumor or tumor which is in the premolar area, you can do this marginal mandibulectomy with various maneuvers. intraorally also by raising the cheek flaps. If your marginal mandibulectomy goes posteriorly, particularly in retromolar areas, where you want real good control, if the patient is having trismus and the exposure is a problem, you would like to do it with an cheek flap exposure or angle mouth or midline split exposure.
Right. And how would you decide about which cheek flap incision to place? Whether you would take a midline split versus take an angle split? How do we decide that?
So basically, where your tumor is going, if your tumor is encroaching to the angle mouth and your margin is going to compromise the blood supply around the lip, then you will go at the angle mouth because you don't want your angle mouth vasculature to be disrupted and putting a midline lip split, jeopardizing your lower lip.
Yes,
So,
exactly.
so where your tumor is, mark it first, your resection, and accordingly you plan your lip split incision.
Right. Thank you, Dr. Dushan. Another point I would like to say is about the involvement of the skin by the tumor. If there is any possibility of requiring to excise the skin for your third dimension, it is wise to probably take an angle split incision, which maybe easily can encircle the involvement of skin without jeopardizing your lip blood supply.
Yeah, so Vidisha,
Yes.
I totally agree with your point about the looking at the skin. So if the skin may not be like totally ulcerated, but you might require a skin excision. So always mark whenever you are doing a oral cavity cancer patient, always mark first the how much skin you need to excise as your third dimension, and then you place your approach to your tumor. So you can do a safely angle split for most of the tumors, but midline is very selective patients, you will do it. And you have to take care not tumor approaching to the, but you have to think about where the incision you're going to place. The incision, tumor might be posterior, but your incision because of the leukoplakia is going to cut till the angle of the mandible, then you should not take a midline split then.
Right. And for the students in the audience, I would like to say that it is possible to do a marginal mandibulectomy by raising a cheek flap without splitting lip, which is called as a bucket handling. Many of you might be aware of it, but this requires a very good understanding of how your third dimension is going to be taken. So if you are doing this surgery in the beginning part of your career, whether you're not done many cases, I would recommend that you go by traditional approach, perform a lip split, either an angle or midline split, take adequate margins in the third dimension, and then perform your surgery. Once you have done a fair number of surgeries, you are aware of how to take a third dimension without splitting lip, then attempt your bucket handling so as to not compromise onto your soft tissue margins. So the next point, Dr. Abhishek, would you like to give us some important tips or precautions while doing a marginal mandibulectomy? What to do, what to not to do while doing a marginal mandibulectomy? And what sort of instrumentation is better to be used while doing a marginal mandibulectomy?
Okay. First is the shape of the marginal mandibulectomy. The edges should not be right angle. So it is described as cano-shaped or boat-shaped, or consider it as an arc of the circle. The idea is that the masticating forces should not fall upon the remnant mandible at 90 degrees. They should be evenly distributed. Otherwise, this may cause a pathological, a traumatic fracture. So that's one. Sorry.
Go ahead.
Yeah, that's point number one. Point number two is the height of the remnant mandible. The remnant mandible should be at least 1 centimeter in height, so that you decrease the chances of once again causing a fracture. Third is the vascularity of the mandible. Now remember that the mandible will be supplied by its nutrient foramina and also by the periosteum from the buccal and the lingual aspects. So you cannot strip the mandible of all of these blood supplies. Otherwise, that segment of the mandible will become avascular, and there is a chance of osteoradionecrosis necrosis if post-op radiotherapy is to be done. The fourth thing is margin. Obviously, if there is bony erosion, as I said in a previous comment, there should be your marginal mandibulectomy should be done only if a 1 centimeter margin can be achieved. Now, regarding instrumentation, ideally is to have a saw. You can use a sagittal saw or a reciprocating saw. Be very careful as you curve, because the saw is not the perfect instrument to curve. But with a little practice and with a little back and forth movement, you will be able to get that curve. If instrumentation such as saw is not available, you can use fissured burrs. Now remember that this is not the ideal tool for doing a marginal mandibulectomy, but if not all institutions will have a saw, you can use a fissured burr. You can use a 1 millimeter fissured burr. You can do what is known as postage stamping, so that you have marked the marginal mandibulectomy and you have done holes along the proposed line of marginal mandibulectomy using a drill bit, and then you can join these holes using a fissured burr. But remember, the ideal instrumentation would be a powered saw.
Right. And also any experience with the piezoelectric, because this is a new instrument. Maybe the maxillofacial colleagues are more well versed with using a piezoelectric saw, and in certain cases, maybe for an intraoral marginal, it might be a good instrument, but only if, of course, you have availability of the instrument.
Yeah, so I have used it only when it was demoed in our hospital, and I found it a little slow. But yes, it is a precise instrument.
Right. Exactly.
Yeah, I agree with Abhishek. I have also used it. It takes many years to cut the mandible, but if you're not doing a cheek flap and it's a small lesion, you can avoid a cheek flap for the patient. It is a good kind of instrument, and it gives you a very precise kind of excision of the mandible without doing the more morbidity for the patient. So even the reconstruction and everything becomes very easy for the patient. You avoid a scar for the patient.
Right.
True.
So this is the article Dr. Abhishek was referring to about the biomechanical analysis of how the forces are distributed over on the mandible. This is just for the interest. It's a cadaveric study where they examined the fractures of the mandible at different residual heights. And they found that when the height of residual height was more than 10 millimeter, the reduction of bite forces was better, and the height more than 10 millimeters was recorded based on this cadaveric study, which we follow currently. So next, now we
I think Vidisha in 87 articles also actually said the same thing on the fresh cadaver, where incremental weights they have put and they have
put on
checked
the various
on
heights of the mandible.
same conclusion, but this is the latest and very fancy photograph it has got.
Yes,
But
yes.
the
I just thought
87
the
was
residents might just benefit in their exam by telling fancy things.
yeah.
Vidisha,
But the backup paper is the old paper where
Right.
the marginal was based on, and it's again a cadaver study on the mandible, and they kept on doing the incremental osteotomies and then looking at the how much force of chewing they will have. So it's a gauge, basically gauge
Dr.
analysis.
You were saying something?
yeah, Vidisha, I will like to make one point,
Yes.
especially for the youngsters, is that we time and again say that 10 millimeter margin, 10 millimeter margin. Now we have to keep it in mind that 10 is minimum. So when you are doing a marginal mandibulectomy, where the disease is just abutting your mandible, you can actually take in a dentulous mandible a larger mandibular remnant. Larger the mandibular remnant, better is the stability of mandible. So, so never aim that you will just keep a 10 millimeter, because anything which is more than 10 millimeter is definitely going to benefit the patient, not only for the robustness of the mandible, also for your dental guys who are going to make the patient dented again by putting the implants.
Right.
So if you can preserve the larger height of the mandible, better.
Right, exactly.
Yeah, good point. And another point, Dr. Vidisha, would be to factor that there will be some bony loss while cutting. Even if you're using a saw, anticipate a 1 millimeter loss at least.
Totally. Yes, good point, sir.
And one more point about doing a vertical mandibulectomy, like a lingual plate or a buccal plate. So you can only do this procedure only in the body part of the mandible, because you have a medullary cavity. You can't do it in the anterior segment or a posterior segment. So it is only feasible in the molars areas where you can do the vertical marginal mandibulectomy, like a buccal or a lingual plate. because you had to extract the teeth and then you can do the vertical mandibulectomy in that sense.
Right, ma'am, right. So now coming to the reconstruction, so how do we close these defects? What kind of modalities we can use? Just a primary closure, any local flap or free flaps? So where do we use what? Dr. Dushyant, any pointers about this?
So your reconstruction will depend upon many aspects. One is including what is the size of the defect you have created. If you just remove the alveolar tumor and you have unhealthy mucosa in a patient where there is no submucous fibrosis, where you can bring in the mucosa. So a limited resection with unhealthy mucosa, you can do a local flap, which is an advancement flap, which is a primary closure also you can do. In most of our patients, they are submucous fibrosis, and the marginal mandibulectomy is usually used in a GB sulcus tumor, which is encroaching your mandible. So you lose a lot of mucosa, which is not usually be possible to be replaced locally. So you can harvest a local flap, that is a nasolabial flap or submental flap or a platysma flap, or you can do it with any local regional flaps or a free flap.
Right. Thank you, sir. So in the interest of time, I will skip this point on the oncological safety. Suffice to say that there are multiple case series from the hospitals which have conveyed that there is cause-specific survival of over 80% with the local recurrence rates up to the range of 10 to 11%. This is one very old article by Dr. Pradhan, which is said of a 79% local control rate with marginal, but it guards against the exact case choice for doing a marginal mandibulectomy, where they say that a deep infiltrating lesion in the lower GBS, it might have a paramandibular infiltration, even though the mandible is radiologically uninvolved, and where you might end up with a positive margin. So the students should please remember this. Your assessment of the tumor spread in a vertical and horizontal dimension is very important for your safety of doing a marginal mandibulectomy. So now coming to the complications. So what complications do we anticipate in this surgery? Yes, ma'am.
So Vidisha, just one point. So as you said, the soft tissue component is very important. So I would also like to say the prognostic factor, the how's your soft tissue margin in a marginal mandibulectomy is important factors. So if you have a frozen session, you should take care of that soft tissue margin on table, because it's not possible to have a mandibular margin on table, because you have to have a decal reports, then only you can comment on whether you are good on the margins of the bone or no. So these are the indirect methods which you can do it intraoperatively. You can say send some scraping, or you can send the soft tissue, and that will guide you that you are good on your soft tissue margin. These are the most important things which actually takes care of the local control, apart from the prominent pattern of invasion, whether a tumor, what is the thickness and all that. Irrespective of all that, the soft tissue is the most important thing, which is the most important part for the recurrences and the control rates.
Right, ma'am.
So Vidisha, one point which I will like to make in concordance with Anuja, and especially for the youngsters and students, is that in the zest to close it locally, don't compromise in your soft tissue margins while doing marginal mandibulectomy.
Right.
Keep it in mind. Your marginal is not a marginal resection. It has to be a good resection. So have good soft tissue and mucosal margins. Don't rely on primary closure. Always have a backup.
Right, sir. So
I totally agree.
Most common complication now we come to of this surgery, apart from immediate surgical complication of infection, OC fistulas, most worrisome is a pathological mandibular fracture. So Dr. Rajdeep, could you give us some pointers as to what things we should do to avoid pathological fracture in the post-op period, and what are the risk factors?
So starting like the instruments that you use, preferably use the saw, or like what Abhishek Vaidya has pointed out, use the postage stamp method. So that goes in a long way to prevent surgical fractures. Then you should not have, like Dr. Abhishek again pointed out, not have sharp corners. You should have it like a board shape or cano shape, so that the forces of mastication get distributed evenly, and so fractures can be avoided. And then finally, you should have a good residual amount of mandible from the lower rim possible, so that when the bite forces happen, these things can be avoided. So these, like what all we have discussed, they are basically to prevent the pathological fractures only.
Right. So there are certain studies which reiterate the same points which Dr. Rajdeep has said. So this is one of the interesting studies which have told that there are higher chances of osteoradionecrosis when the patients are receiving concurrent chemoradiation with the radiation doses more than 60 and the patients who have been smoker. Also, this study, which is a 23 recent study, it says that the chances of ORN are more likely in a mandibulotomy as compared to marginal, but this could be a bias because this is a very small cohort and the patient numbers are unequal. Another important study, which is a very interesting study, which you all should know, this looks at other risk factors, which are for mandibular pathological fracture. So this talks about a mandibular body height preservation ratio, that is the ratio of the mandible resected versus left behind. So if the ratio is more than 0.3, if there are more than 20 remaining teeth post-surgery, and if inferior alveolar canal exposure has occurred during marginal mandibulectomy, so these are high-risk features which could lead to post-op fracture in these patients. So these people also, also said that patients who had prosthetic teeth in the remaining jaw are likely to have more fractures because they have stable occlusion and strong occlusal forces which could fracture this mandible. So this is an interesting study which has come recently, which gives more pointers such as chemoradiation, height of the dentate mandible left behind, and dentition of the residual mandible. So these things also should be looked into. Any other pointers would anybody like to tell, Dr. Abhishek, Dr. Dushan, to prevent pathological fracture? Any surgical things?
So I've seen some surgeons use a recon plate after a marginal mandibulectomy. If your technique is correct, if your technique is correct, if the shape is correct, if the remnant bone is adequate, you don't need to do that. In fact, it will increase your chances of ORN and ORN. So that is one thing you should avoid. The other thing, as has come out in the study, is, as I said, the three ways the mandible receives blood supply are from its periosteum of the buccal, lingual aspect, that's two, and from the nutrient canal, which is the inferior alveolar nerve canal. So if you're raising a cheap flap, your buccal, cortical, periosteal blood supply is already gone. So always try to prevent the loss of the exposure of the inferior alveolar nerve canal and the loss of the blood supply from that part. So that is an important thing.
Right. So this study also says that, yes?
Yeah, Vidisha. I will say that the weakest part of the mandible will be at the third molar.
Right.
So anatomically, if you see at the antegonial notch, the mandible becomes the thinnest. The last molar, once you do a marginal mandibulectomy at that area, you almost have non-existent inner cortex. So your mandible is barely on your outer cortex, and if your measurement is not good, then you can be less than 1 centimeter at the antegonial notch and at your marginal portion. So whenever your marginal is going to go to your last molar, be very careful in considering that.
Right. And also this is the commonest site where intraoperative fractures also will happen when we don't have availability of instruments such as reciprocal saw. We are doing with a maybe micromotor. We are tempted to use some small amount of chisel and mallet, which I would guard everyone against. This is the site where a fracture would happen intraoperatively also. So that I always tell my residents not to be tempted to just take a chisel and mallet and try to take out that last part of marginal. You will definitely have a fracture on your hand. So please be guarded against this.
Yeah, so I agree totally that be patient till the end, till the specimen comes as a nicely in a boat shape. So just a point about how to avoid the osteoradionecrosis. I feel we underestimate the defect and we try to do the defect with the good soft tissue margins. And when we reconstruct, we use some small flaps for the patient. So we should be judicious to use a free flap so that you have enough of a soft tissue cover over the mandible so that that mandible can withstand the radiation toxic effect, so that though you have preserved the inferior alveolar canal, the blood supply, which is one of the things where the mandible actually surviving, that will be prevented and your mandible is not exposed. Because when you're doing the cheek flap, you will have a very less tissue in between the mandible and the skin. So the point should be taken that you select the patient properly. Don't overdo a marginal mandibulectomy just because you wanted to save the mandible. If you are not happy, maybe a segmental is the choice for that patient. So you have to do a proper selection and a proper reconstruction for the patient.
Right. The good soft tissue cover after surgery is utmost important to prevent necrosis of the mandible after radiotherapy. Right. Now, coming to the last point, how do we rehabilitate these patients dentally after marginal mandibulectomy?
Dental implant with
Pardon me, everybody is speaking. Can we mute the mic? Maybe some participants' mic is open. Yeah, thank you. Yeah, so what about the rehabilitation after doing a marginal mandibulectomy? How do we do dental rehabilitation? Dr. Dushan, Dr. Abhishek, any words on this?
Yeah, so dental, implants are feasible if the remnant height is enough. You can have long implants. We haven't done many, but these are feasible. Some of my patients who do not have a bulky flap have received partial removable denture also. But that is in my limited experience. Apart from that, I haven't had much experience with using implants. I've only recently started doing that.
Yes, and for the partial removable denture, other factors such as having an adequate sulcus and having a particular height of the mandible would also be important, and also other teeth also should be stable enough to support a removable denture. Those all factors also should be considered.
Absolutely. Yeah.
Dr. Krishant, any pointers on this?
So whenever you are using implant, you are actually trying to reconstruct or give the teeth up to first molar, maximum to the second molar. It is especially very useful for the central arch defects where your structure of the remaining mandible is wide and very robust. So you can put multiple implants, around 3 or 4 implants, and do a good central arch rehabilitation. But as you go posterior, it becomes a bit difficult for your implantologist to put implants.
Right. So there are isolated case reports where they have recommended a fibula over marginal for placement of implants, but it might not be practical in all centers, and it's only anecdotal a few case reports. So this is something I just came across a case report of rehabilitation of mandible after marginal using basal implant reconstructive prosthesis. These are longer implants which have a special arrangement for the implant to stay in a marginal mandibulectomy. So these case study claimed 100% success rate. Again, this is from a single center and may not be widely replicated. And they have claimed that there was a 100% success rate of their implant even after 16 months of follow-up. So this is one of the ways a patient can be rehabilitated, which could be a possibility, is what all you guys need to know.
So another important point, if you're using implants, is the timing of the implant. If you're anticipating radiotherapy, then the timing of implant is very important. Remember that this bone already has a less height and there is a high risk of osteoradionecrosis. So I would delay the implants.
Right. So this is a maybe
just a point about giving implants for a patient who has underwent a marginal. If you can see, it is very difficult to give a implant in a patient who doesn't have a height. So what people are doing, that they are putting a fibula over the marginal and then using an implant. But I think it is an overkill to do both the procedures. And so you have to select a patient again properly. Maybe a candidate who doesn't require a radiotherapy is a patient where you can put this long implants, and long implants also can give you a pathological fractures, because if you can see, it is just reaching till the lower cortex. So you have to be very careful when you are selecting a patient who is not going to receive radiotherapy. Maybe that candidate I will choose for the primary implant, or maybe a fibula along with the marginal will be a choice to do a routine implant, what we do it. And that's how I think MSKCC people are doing a fibula over the marginal mandibulectomy. But I don't have much of experience doing implants on a marginal per se directly. Maybe a denture only based things I will use it for the patient.
Right. Okay. So
Yeah,
as
for
Ma'am,
the
sorry to
for the
interrupt.
end.
Ma'am, sorry to interrupt. We are running a bit ahead of time. So can you please
Sure,
wrap
sure,
up in 2
Yeah.
minutes? Thank you,
We are
ma'am.
done, Mansi. This was my last slide. So I'd like to thank all my expert panelists for their valuable comments. This was a great discussion. Thank you, everyone.
Thank you.
Thank you. Thank you.
Thank you. Thank you.
It was a nice present. Yeah. Thanks.
Thank you, Vidisha ma'am, and the respected panelists for this excellent detailed discussion on marginal mandibulectomy. So we will move on to the next session, which will be the third session for. The third session will be on operative technique discussion, infrastructure maxillectomy. The expert panel for this session are Dr. Ashok Das, Sir is Professor in the Department of Head and Neck Surgical Oncology at B. Bura Cancer Institute, Guwahati. Dr. Caleb Harris, Sir is Professor and Head of the Department of Surgical Oncology at Northeastern Indira Gandhi Regional Institute of Health and Medical Sciences, Shillong. Dr. Asim Mishra, Sir is Officer in Charge, Professor in the Department of Head and Neck Surgical Oncology at Tata Memorial Center, Varanasi. And Dr. Buranuddin Kayumi, Sir is Associate Professor in the Department of Head and Neck Surgical Oncology at Tata Memorial Center, Muzaffarpur. This session will be taken by Dr. Ratan Shetty. Sir is Associate Professor in the Department of Head and Neck Surgical Oncology at Tata Memorial Center, Actrac, Navi Mumbai. I request Sir to kindly start with this presentation. I have stopped sharing my slide.
Yeah. Thanks for the opportunity. Am I audible?
Yes, sir, you are.
Yeah. So I'll be discussing, mostly I have few videos I'll show them and I'll ask questions to the panelists. I'll start sharing the video. So today I will be talking about infrastructure maxillectomy, an operative technique. So coming to the anatomy of the maxilla, it has three processes: the frontal process, the zygomatic process, and the alveolar process. And it contains the maxillary sinus, which is a three-sided filament lying on its side. We have to know the intricate anatomy of the maxilla to perform various maxillary cuts. This is another picture showing the soft tissue relation to the maxilla, the infratemporal fossa along with its muscles and various nerves entering the various foramina. The most chief would be the mandibular nerve, which will enter which will give us the inferior alveolar nerve and the pterygopalatine ganglion here. Now coming to the panelist, how often do you do infrastructure maxillectomy? Dr. Ashok, sir?
Yeah, Ratan, good afternoon, good evening.
Sir. Good evening to all the panelists.
So, in India, we in our settings, actually, pure maxillary tumor is not very common. All the maxillectomy procedure actually we perform for oral cancer, mostly the upper alveolus or the hard palate. So we see quite a lot of upper gingival and gingival cell cancer, upper GBS cancer, for which we actually do the partial maxillectomy procedures. And of course, it's less than the mandibular surgeries, but it is not that uncommon also. So we do.
Yeah, and also we do it as part of bialveolar resections. Most of the surgeries
Correct.
which involve infrastructure maxillectomy would be for buccal mucosal cancers involving the upper GBS. As part of your bialveolar resection, we do infrastructure maxillectomy. Like sir said, the incidence of primary maxillary sinus or the hard palate lesions are not very common. Upper alveolus, yes, usually involving the upper GBS, can cause involvement of the upper alveolus. So if there is a significant maxillary sinus invasion, would you still go ahead and do an infrastructure maxillectomy? This question is for Dr. Burhan. What would you do?
There are specific indications, as Sir rightly, Ashok Sir was rightly saying that essentially in India we end up doing some form of mandibulectomy or infrastructure maxillectomy for oral cancer lesions. When there is gross involvement of the maxillary sinus, or when there is a retroantral involvement which is going very high up, it is actually a relative contraindication to be doing a partial or infrastructure maxillectomy in that case. So that is a short answer to that question, but then I am sure they can.
No, we will keep it short and simple so that we will not
Yes.
overshoot our time. Okay, we know the indications. Most of the time, the indications are oral cancer involving the upper alveolus, and very rarely we do get palatal lesions where we would need to do infrastructure maxillectomy. A primary maxillary sinus tumor requiring an infrastructure maxillectomy is very rare. One is because a primary maxillary tumor manifesting itself early is not very common. Okay, so what is the extent of the resection? As by definition, there are various maxillectomy classifications. Infrastructure maxillectomy is not a very accurate term, it's a vague term. So as part of resection, we remove the hard palate, the lower part of the maxilla, the orbital floor will be kept intact, and we do an appropriate reconstruction. So coming to classifications, there are various classifications, more than 10 different types of classifications. Dr. Asim, what classification do you follow, and what is the relevance of classification systems for classifying maxillary sinus defects or maxillary defects? Asim, is Asim with us? Hello. Yeah. Dr. Caleb, are you with us?
Yeah. Hi, Ratan.
Yeah. Hi, Dr. Caleb. This is the most commonly used classification system, the Brown's classification system, which has a horizontal component and a vertical component. The vertical component causes more, higher the vertical component, more is the aesthetic deformity. Higher the horizontal component, more is the functional deformity. If you have a large palatal lesion, the functionality, that is the ability to swallow and ability to speak, gets affected. So basically, it is a classification system to convey the results between each other. So Brown's classification has a vertical component where the alveolar ridge is resected, that is class 1. 2 is the infrastructure maxillectomy. 3 is involvement of the orbit, the total maxillectomy. If orbital exenteration is performed, it is class 4 defect. Class 5 is orbito-maxillary defect, which is between also suprastructure maxillectomy. And 6 is naso-orbital defect. Horizontal component, again, only a palatal defect, 1/2 of the palate, anterior palate, and more than 2/3 of the palate. There are various other classification systems, the corderomaxillectomy classification system and OK classification system. The OK classification system is by prosthodontists, where the ability to use a prosthesis for a maxillectomy, post-maxillectomy is used to classify the defect. Class 1 is a small defect involving the center of the palate. Class 1A is anterior maxillectomy defect. 1B is either a premaxillary defect or 1/2 of the palate, less than 1/2 of the palate. Class 2 is 1/2 of the palate where the canine and the premolar on one side is, or the molar on one side is resected. Class 2 again less than half of the anterior palate is removed, is also a class 2 defect. Class 3 defect is 3 pivot structures, 2 canines and 1 molar, or entire palate, or more than 50% of the anterior palate is resected. So the ability to use prosthesis is not there because you have only one stable structure which will hold the prosthesis, so you will not be able to do any obturator closure. So would require free flap reconstruction or any form of reconstruction for that. Now coming to the incisions for maxillectomy, what are the various incisions that we use? What is the commonly used incision for maxillectomy? Dr. Buran, could you describe various incisions for maxillectomy or for infrastructure maxillectomy in this case?
Burhan, you are muted.
Buran?
Please unmute.
Yeah, sorry. I'm so sorry. So thank you, sir, for that question, and I'm extremely sorry for not
So,
realizing that my mic was muted.
yeah,
So
yeah,
basically,
yeah.
maxillectomy can be done by our various methods. Traditionally, it has been done by the Weber-Ferguson incision, and it has basically the lip split component and the lateral rhinotomy component. Essentially, when we are referring to partial maxillectomy, we do not have to have a lynch or the orbital extension for the maxillectomy. And we generally tend to use only the lip split with the lateral rhinotomy incision and that is generally sufficient for us to gain good access and posterior access as well. At times, when we have certain cases in which some part of the coronoid process and the marginal mandibulectomy also needs to be done, we may do angle split approach also may be taken, or in cases where already it's a salvage case. In those cases, doing a traditional Weber-Ferguson or a midline lip split would land us in devascularizing the lip. So yeah.
Yeah. And another question: when would you do a peroral resection?
Per oral resection, it has to be limited to basically either if it's in the premaxilla, and if it's a very small lesion, we can do a per oral excision with no OSMF, but generally it is to be avoided. I feel because three-dimensional clearance becomes an issue, and for the young surgeons and for all of us, I think it's better that we have good oncological clearance, and only if it is anterior and it is limited in size, I think that's the indication.
Yeah, thank you. If it's an anterior disease involving only the the anterior teeth, alveolar ridge, we can safely do a peroral resection, but achieving three-dimensional margins is paramount in resecting oral cancer. So if you have a posteriorly based lesion, always put a incision on the face to access the tumor from all sides. Coming to this question, Dr. Caleb, when would you do a neck dissection for oral cancer involving maxilla?
Yeah, as everyone said earlier, so generally we end up doing infrastructure maxillectomy mostly for upper GBS, upper gingivobuccal sulcus cancer rather than a maxillary cancer. So one is when there is a lot of disease in the upper alveolus, especially those extending to the buccal mucosa also we need to consider. And of course, if there is clinico-radiological evidence of any neck nodes, we probably have to do.
Yeah, thank you for that. Dr. Ashok, you agree with Dr. Caleb?
As in the beginning, I say is that most of these maxillary surgeries we do for oral cancer actually. So definitely we need to address the neck. But yes, if there is a T1 lesion in the heart palate, we can think of that.
Yeah. If it's a small oral lesion in the palate, yes, we may not do a neck dissection. But Buran, what do you say to this?
So there are multiple, there's a lot of retrospective data, and even there's systematic reviews which do say that the incidence of neck node metastasis is quite significant. Although these are all varied studies, a lot of heterogeneity in those studies, but yes, there is quite significant incidence of neck node metastasis, and I would err towards doing a neck dissection unless until patient is in a trial or we have other methods like sentinel lymph node or things like that.
But I see the evidence is systematic review is only as strong as the individual studies which are included. But I do agree that if the small primary tumor in the palate not involving the bone, T1 disease or even a T2 disease, we may not do a neck dissection. But most of the time we end up doing a neck dissection. One is for reconstruction. Also, if you're planning a free flap, definitely you should do a neck dissection. to access
Yeah,
the neck.
and sometimes, I just wanted to, you very rightly said, sir. Sometimes it's in the midline palate, and then ideally, the lymphatic drainage, and if we do not have a proper mapping of the lymphatics, then ideally we should be doing bilateral neck dissection. So then, where does the buck stop at times? So that could be one thing.
That may be an
Yes,
overkill. And the first echelon
yes,
node for a palatal disease is the retropharyngeal node, not the
retropharyngeal node,
not the
exactly.
not
So
the
it's hard to sample that node as well. So.
Yeah, I do even with all our panelists. Yes, we end up doing neck dissection most of our cases, but in certain cases where it is a limited disease, T1 disease in the palate, yes, we may not do a neck dissection. Many a times we end up doing neck dissection. And now coming to steps and tips of doing an infrastructure maxillectomy. What is more important? Reading the scans. So what is the ideal imaging for a palatal lesion or a lesion involving the upper alveolus? Dr. Caleb, what investigation would you order? What are the
Generally we'll start with a CT scan, and in cases wherein we need to study if the bone invasion is not there, where there is a doubt, we'll ask for an MRI also.
Dr. Asim, has he joined us? Dr. Asim, is he with us? The organizing team, has Asim joined us? No. Okay, so we'll read the images, plan the incision. We have discussed what incision we would be planning. Now raising the cheek flap. So that is also part of the incision. If you are raising a cheek flap for oral cancer lesion, yes, we will take adequate margins on the cheek also. Soft tissue cuts, complete the soft tissue cuts before the bony cuts. Complete the bony cuts, achieve adequate hemostasis and reconstruction. We will discuss each and everything. Now coming to this case, here you have a lesion in the oral cavity involving the hard palate. The lesion is posteriorly located. You have the imaging here. You can read the imaging. This is the axial sections. Sorry. To the panelists, do you see something here? Something unusual here? Dr. Buran? On axial section? I have my pointer pointed here. What do you think this is?
It's probably there's a small.
Yeah, this is a. I'll give you. This is a posteriorly located region in the region of the greater
Yes.
palatal foramen. So you can see the disease
Yes.
creeping along the greater palatal foramen.
It is it is in the fissure area, sir, almost near the
Yeah.
fissure.
Yeah, perineural spread. But it is only reaching the greater palatal foramen, not creeping along the nerve all the way. One of the confirmatory findings would be do an MRI scan. I'll play the video again. Yes. It's not involving the maxillary sinus, reaching up to the floor of the maxillary sinus. Now to the panelist, Dr. Ashok Das, sir, what would your resection be? And what incision would you plan for this patient?
Ratan, before, I'd just like to ask, what is the histology of this tumor?
It is a squamous cell carcinoma, sir. Sorry for not telling you the histology. We'll do a biopsy. We'll do a biopsy, and biopsy shows squamous cell carcinoma. So how do you plan the incision for this patient, and what is the extent of your resection? Of course, we'll do a neck dissection for this case. So fairly large tumor. So what would be the incision? What would the incision be?
So it's little posteriorly located tumor. So a classical Weber Ferguson incision I'll definitely make, which will give us sufficient exposure, particularly bony for bony margins. We need to reach up to the level of zygoma and to go to the posterior lateral surface of the maxilla, and we need to take a cut around taking the maxillary tuberosity, and maybe here in the palate we may need to cross the midline. as I'm assuming this lesion is almost in the midline. So the my approach will be a classical Weber Ferguson incision, taking the flap and then deciding on the bony margins, as I say, up to the zygoma. But clinically doesn't look like a typical squamous cell carcinoma. That's why I asked you.
Yeah, we also suspected that it's not a squamous cell carcinoma, but it turned out to be a squamous cell carcinoma. Look like a minor salivary gland tumor to us.
Correct.
Yes, it looks like a minor salivary gland tumor, but it turned out to be a squamous cell carcinoma on biopsy. We have not operated the case yet. This is a pre-operative case, so we have not planned the incision. We have not done the surgery. This photo I took 3 days back in the OPD. So yeah. So Buran, what would your reconstruction be in this case? What reconstruction?
So, sir, what generally, essentially, we will be we'll be resecting almost crossing midline, as sir said, and even anteriorly, I think some part of the premaxilla also would be sacrificed in this case. So it will be a kind of an extensive palatal defect as well. So if you go by classic Brown, this would be a class 2C defect. And then if that is a scene, ideally it should be reconstructed with a free flap, because we'll have to at least give some support to the anterior alveolus, and preferably a bony support. But otherwise, in setting where we do not have free flap availability, or due to various reasons, if free flap even though if it's available, it's not accessible, then obturator can be done with additional clasp, and we can have some retention to that. So I think I would in the current setting I would go ahead with an obturator.
Dr. Caleb, you agree with this, Dr. Ashok Das, sir?
Yeah, I very much agree, because we also, the availability of free flap is a concern.
Yes. And what would be the flap be? It will be a soft tissue flap or a bony flap, Dr. Puran?
So ideally, sir, if it would be a slightly lesser one, even an FRAF would actually better. Just giving a lining also improves the further rehabilitation, the dental rehabilitation of the patient. So, but in this, if the significant premaxilla is going to be sacrificed, a bony reconstruction should be done.
The determinant for a bony reconstruction is the aesthetic component, that is the premaxilla. If premaxilla is involved, you would do a bony reconstruction. But in this case, I think you can still escape doing a soft tissue flap. I think doing
soft
a
tissue.
bony flap, yeah, bony flap.
Fairly agree, sir. Yes.
Yeah. Now I have another video presentation. This is a 35-year-old male, ECOG 0, presented with the ulcer in the hard palate on right side since 2 months, tobacco chewer, mouth opening is adequate. There's an ulcer measuring 1.5 into 1.5 centimeter on the palate, opposite premolar. The GBS, the mucosa, buccal mucosa, the alveolar ridge, the retromolar trigones are free. No palpable neck nodes. Histopathological diagnosis is MDSCC. CT scan involving floor of the maxillary sinus with oroantral fistula. I do not have the imaging with me. I misplaced the images. I don't know where the images are, but I have the video with me, which was the surgery was performed by one of our colleagues. You can see the incision. You can go ahead and comment on the steps of surgery. It's a 13-minute video of infrastructure maxillectomy being performed for a palatal lesion.
It's a very nicely made video, I think.
Yes. Not performed by me, I had to disclose. And we have done
the
a neck dissection here. The neck dissection has already been performed. The incision has been marked. The infiltration is
so
given.
some tips, yes, sir. So some tips here, so that we need to be bang in the midline, and using either the filtral ridges doesn't actually really help, though that has been traditionally also been tried.
Yes,
Also,
The Altamir,
Yes.
sorry for interjecting, the Altamir incision which runs along the filtral ridge was described supposed to be giving good cosmetic deformity. By and large, most of us do use Weber-Ferguson incision, go bang in the midline and go into the nasal vestibule and curve around the ala of the nose. The entire Weber-Ferguson was not used in this case, only part inferior aspect was used. We mark the mucosal incisions all around with at least a centimeter margin. The mucosal contraction in the palate, hard palate, is actually lesser than the other soft tissues. So what we are measuring a centimeter margin all around and deepening the incision. So whenever you do any oral cavity resection, remember always complete your soft tissue cuts before your bony cuts. So we are marking the soft tissue cuts here between the palate and the soft hard palate and the soft palate. The incision is deepened. Fairly well recorded video, and remove only as much as it is required. The incisor on the side of the disease has been left behind. Why? Because it does not need to be removed. We have got adequate margins all around. And could we have preserved the palatal the alveolar ridge? No, because the lesion is quite not as small as it appears to be. And preserving only the alveolar ridge would have been difficult. So the alveolar ridge has been taken along with the specimen.
So, Asim sir used to, in very limited cases, sir, not in this case definitely, but in certain cases, Asim sir used to also, if you can extract the teeth and then preserve, do a sagittal preserving alveolus on the buccal plate.
I agree with you. Always preserve.
I have tried once. I have tried once. Yes, that's the only because very limited indication.
The lesion is actually around this much, and it is reaching the midline. This is the midline.
Yeah, no, not in this case, sir, but just as a discussion, that can
please,
be.
Please, Dr. Caleb, Dr. Ashok, sir, please go ahead and comment on the
So Ratan, how we have intubate this patient? Like we did tracheostomy or?
Yeah.
Okay.
Tracheostomy
So what happened many a times when we put a tracheal tube in nasal intubation, mostly we do in this kind of patient, limited surgeries. So one thing we should take a note that there's some distortion of the facial and nasal landmarks that occurs with the taping of the endotracheal tube. So it is better the incision marking should be delineated with a marking before the intubation, it seems like. So otherwise, after putting a tube and after taping, there is usually some sort of distortion of the landmark. So that one point. And secondly, for whether it is partial or any kind of maxillary procedure, we should be little well prepared. Like a small thing like suction machines should be proper, and because there can be breaks of bleeding after the bony cut at any point of time. So to deal with those kind of situation, we need the other instrument be at hand. And yes, you have rightly mentioned, Ratan, that we should complete all the soft tissue cuts before we start the bony cut.
Bony cuts, yes. Here, the surgeon initially started without putting a facial incision, but the intent of putting a facial incision was there. So he has marked the incision. It was not an unplanned step. So all the soft tissue cuts, why the facial incision are not put is because the moment you put a facial incision, it starts bleeding. So to avoid bleeding, he has just done all this, and now he is proceeding on to the lip fluid incision. So Burhan, how would you take the lip cut? What instrument will you use to cut the lip?
Like we can use the knife. That would be. We can also use
you can use a straight knife, that is the 11 number knife, to cut the lip. That gives a straightest incision that is possible without much of soft tissue loss. But yes, each to his own. Whatever you are comfortable with. Yeah, whatever you are. It's not like a hard and fast rule that you have to do.
Yes, and if it's basically a high energy with
Yeah, in pure
in
cut
a good
mode,
cautery system. Yes,
yeah, you would be able to put a precise incision.
exactly.
Pure cut
So,
mode would
exactly.
achieve most of
Well,
what a sharp knife could.
this lesion is more more limited to the palatal aspect. If there would be some alveolar component to this and margins with that, there's one point to note for the participants and everyone. Probably many people already practice that way. Is that we need to take the coronoid process as well, because essentially for two reasons. One is that we need to get the third dimension correctly, and also if you're planning an obturator, okay, that really prevents it helps in the retention of the obturator.
Prosthesis.
Yeah, processes. Yes. So
And to access the posterior aspect of the maxilla, if you have a coronary intact, you'll not be
yeah.
able to access the posterior aspect. You can do a
Yes.
coronary access the posterior aspect of the maxilla. Most of us do end up resecting just the coronary portion just to achieve access, but not in yeah. It's a may not be in this case, but yes, we. Dr. Caleb, I mean, most of us trained at the same center, so our steps would remain the same and very similar to each other. So he has completed all the soft tissue cuts. You don't need to remove a lot of soft tissue in the lateral aspect. The reason being because there is no tumor there. You can just hug the bone and resect.
I think removing doing the coronarectomy will also help in the mouth opening post-op also.
Yes.
That all.
Yeah.
Yes.
Excellent. It's a very good point. That is the temporalis muscle that was exposed.
Yes, and point very well demonstrated in this video is that the kind of facial incision taken in this this demonstration is limited, so that whatever is required for the exposure, and here only till the inferior turbinate, they are we have raised the flaps so that limits the morbidity.
Yes. Just because for the sake of incision, do not put an incision which is not required. You can modify the incision as per the case. Every case is different, and whatever is required needs to be removed. Don't remove structures unnecessarily because it will lead to long-term morbidity. Soft tissue, the striker saw system is used to cut the bone. So
Yes, this
This video-
reciprocating saw is a very good instrument. Rather, in many times, anterior disease, we need not have to even raise the sick flap. We can just retract and can take out this
yes,
anterior tumor without raising the without splitting the lip.
if there is a tumor here, I don't think you need to put a lip split incision here. You can take adequate margins all around, and with the incision in the gingival labial sulcus, you can. But yes, always not at the cost of soft tissue margins. Always take soft tissue margins for oral cancer. About a centimeter of tissue all around.
Yeah, and one point is that this sir very rightly said this instrument is one of the greatest gifts to surgery from orthopedics, and really the work done by Dr. Stryker way back, I think more than 60-70 years back, and then to evolve into these finer instruments is a great help in performing these surgeries. So
yeah, the one of the cuts, the posterior soft tissue cuts have not been taken. That's why the tumor, the palate appears to be stuck there. The incision will be, the soft tissue cut will be performed, and the tumor will just fall off, or the specimen will fall off.
Yeah, one practical point about using such saws is that it will be a good idea to activate a saw and then take it to the bone rather than getting into the bone or the groove and then starting the.
Yeah. Good point. Good point there. Yes. and keep control on the saw system. Don't cut unnecessary structures. It is stuck at the pterygoid muscle area. The pterygomaxillary dissection needs to be done, and the tumor can be removed. See, one good point is I'll show you the specimen at the end of the procedure. All the maxillary cuts are perfect, and nothing more, nothing less has been removed. This is the pterygomaxillary disjunction which needs to be done. The pterygoid plate and the pterygoid lateral wall of the maxilla. Sometimes it is harder to access the posterior structures. The cuts have been performed and the tumor is excised. So there is some bleeding here. The pterygoid muscles are intact here.
This is a really excellent surgery. I would say the specimen come into the only thing we need to see the remaining maxillary mucosa. If the mucosa is normal, no signs of chronic inflammation, then we can leave as such.
Yeah, all the margins are intact. You can see the anterior wall. There's some septation in the posterolateral wall of the this is the posterolateral wall. This is the maxillary sinus septation. Even the medial aspect, you have adequate margins. So that is one important cut. You need to cut all around, and the margin seems to be adequate. Okay, so very nicely done surgery by one of our colleagues.
There is a question, sir, regarding the tooth or something. I think remove the tooth. I think it's not required to remove the tooth, Dr. Prahlad. We need to know where the possible roots of the teeth are, and then you can just go bang, preserving enough bone around.
Okay. This is another case, which is a case of buccal mucosal tumor, where there was a lesion in the buccal mucosa, alveolar bone erosion was present, disease creeping along the retroantral space. Here we needed to do an infrastructure maxillectomy. For lack of time, see, I will not be going into the video presentation. You can see the tumor here along the buccal mucosa, creeping along the posterolateral wall of the maxilla. So, Caleb, what would be your approach for this case? What will be the extent of your resection? This is a buccal mucosal tumor involving the posterolateral wall of the maxilla. Here we would require an infrastructure maxillectomy. Would we do something else? Like this case was done 2 years back. The patient is still alive. Per primum case without neoadjuvant chemotherapy. The T4B tumor. So what will be the extent of the resection?
I will go for a. You said the retromolar trigone is involved, right?
Yes, yes.
So I will go for a posterior segmental mandibulectomy along with the infrastructural maxillectomy.
Yeah, excellent, excellent. That all of us agree on this point. We would do this. But what about the soft tissue action, Dr. Buran? What would you do? The soft tissue extent.
So it is
creeping along the posterolateral wall of the maxilla.
Yes,
Low
yes.
idea.
So I am tempted. I would tempt to do a compartment, a kind of a compartment resection, because it is abutting the it's just abutting the middle pterygoid muscle there. Okay, and there is posterolateral involvement, and although the lateral pterygoid is nicely seen free, for adequate resection, depending on the clinical extent, and sometimes if it is the way it is clinically also to correlate, I would end up rather doing some form of it would be mostly a compartment resection for this.
Ashok sir, do you agree with Buran? Do we need to do a
Yes,
compartmental resection?
correct. The more the lesion is situated posteriorly, the clearance should be absolutely adequate. I would rather go to clear the. I mean to say, I would like to take the lower part of the pterygoid plates with the pterygoid muscles, so that will give me a proper clearance of this disease. I'll go and I'll clear as much as possible posteriorly, because this kind of situation in this kind of tumor, if God forbid, if there is any recurrence or other thing, there is no sense of salvage. So the posterior soft tissue clearance should be absolutely adequate.
Yeah, we agree with all of you, and we did perform. This was performed 2 years back. Did a posterolateral, the entire soft tissue was removed along with the lateral pterygoid muscle also. So ITF clearance was done. This is the temporalis muscle, the lateral pterygoid muscle, and infrastructural maxillectomy was performed. And the patient is still alive. See the post-op defect. You can see the disturbing of the sphenoid, the floor of the orbit.
Very beautifully.
There was no skin involvement, so midline lip split incision was placed with a kind of like a McGregor incision, and yes.
One point, just a point. So sorry, sir. If one point is that when we are taking these cuts on the palate and make sure that the soft tissue also we sometimes because it's more for a margin and we the mouth opening is less, and one point for everyone is that please use cutting current. Okay, make sure that you do not devoid the palatal mucosa so strip it recklessly. It just affects your flap, or if you are placing a flap there. So that's one area where where even I'm guilty of it. That I used to be a little less careful, and that's something which I think we all can try to improve.
Buran, you're one of the best
Sir,
surgeons.
sorry to interrupt.
Yeah.
Sir, if you can please wrap up in next 2 minutes, sir.
Yeah, done. So briefly about reconstruction. What reconstruction would you use for most of the infrastructure maxillectomies that we do? As part of oral cancer resection, yes, we'll put a free flap or a pedicle flap. But for initially the first video that I demonstrated, what would be the reconstruction that you'll use to the panelists? Buran?
Sir, obturate. I'm good with obturate. So,
yeah, you can do an obturator. Yes.
Yes.
Dr. Caleb?
Yeah, I would also will line the cavity with a skin graft and then send for a obturator. That too, we can only send for a delayed obturator.
Coming to reconstruction, anything new regarding reconstruction, especially with regard to obturator? We all know what the flap that can be used for palatal defects. There's something called zygomatic implants. Does anyone among the panelists have any experience with this zygomatic implant?
No, Ratan, no.
Sir, not done, but when we were doing our post graduation, that time we have used it. These zygomatic implants, they're very expensive at that time. This more than 10 years back, but
Even
it has
now,
evolved a lot now. Now it has evolved a lot, and I think at Parel, the prosthetics department is using it in limited cases. So they have some experience, and it just gives, because if you use the maxillary bone, the zygomatic bone properly, and with stereolithographic modeling and with virtual planning, I think it is the way forward. I think we should offer it to our patients wherever possible.
And what are the complications? What are complications will you expect? Intraoperative or immediate postoperative complications?
Bleeding is something which we all have to be very mindful of. I would say every case is different. Okay, and as sir said that please access. The problem is that bleeding leads and bleeding begets bleeding. It's like that now you just, because what happens, everything starts getting stained, and so keep your suctions well, as Ashok sir rightly mentioned. And your inappropriate bony cut while the control force you are using, if you are using osteotomes, that is something which is very important. Ensure that we don't use excessive force there, and that's precisely the major ones.
Yeah, thank you,
Anybody else?
Buran. Thank you,
Sorry.
Thank you, Caleb.
Yes.
Thank
Thank
lack
you,
of
sir.
time,
Thank
I
you,
think
sir.
we'll have to conclude. Half an hour is now. I think we should. I mean, picture speaks 1,000 words, and demonstrated a video of an infrastructure.
But you have
No, but the
covered it
video
very
was,
nicely written.
yes, sir.
Congratulations and thank you
Thank you,
always.
Yes,
sir.
sir.
Thank you for
Yes,
all
sir.
the.
The video covered everything actually, essentially everything. Sir. Thank you, sir.
Thank you.
Thank you.
Thank you.
Thank
Thank
you.
you. Dr. Mansi can take over.
Thank you, sir. It was a great discussion and a wonderful presentation. Moving on to the next session for today, which will be on Kate's presentation and discussion on advanced stage oral cavity carcinoma, T3, T4, and N+ disease. The expert panel for this session are Dr. Elizabeth Ipe. Ma'am is professor and head of the Department of Surgical Oncology at Regional Cancer Center, Trivandrum. Dr. Vipin Arora. Sir is Director, Professor of ENT and Head and Neck Surgery at University College of Medical Sciences and GTB Hospital, Delhi. Dr. Chandrasekhar Dravid. Sir is Professor in the Department of Head and Neck Surgical Oncology at Tata Memorial Center, Mumbai. Dr. Richa Vesh. Ma'am is Professor in the Department of Head and Neck Surgical Oncology at Tata Memorial Center, Mumbai. And Dr. Anuj Kumar. Sir is Assistant Professor in the Department of Radiation Oncology at Tata Memorial Center, ACTRAC, Navi Mumbai. This session will be moderated by Dr. Arvind Guru. Sir is Assistant Professor in the Department of Surgical Oncology at Homi Bhabha Cancer Hospital and Research Center, New Chandigarh. This topic will be presented by Dr. Anthony Raj James. He is an head and neck oncology resident at TMC ACTRAC, Navi Mumbai. I would request Dr. James to kindly proceed with his presentation.
Very good evening to one and all present here. I'll be presenting a case of advanced carcinoma of tongue. So my patient is a 34-year-old male, a resident of Jalna, Maharashtra, farmer by occupation with no comorbidities and family history of cancer. He's a tobacco chewer daily since 7-8 years and stopped since 1 month. So this patient came to us with complaints of non-healing ulcer over the right lateral border of tongue since the last 2 months. And there is also pain over the right tongue, which is referred to the ear since last 1 month. So patient was asymptomatic 2 months back when he noticed the ulcer over the right lateral aspect of tongue, which was insidious in onset, which was initially small in size, and it has gradually progressed over a period of 4 months to attain the present size. It is also associated with pain, which is aggravated on chewing, swallowing, and relieved with painkillers. There is also a history of foul smell from mouth. There is a history of occasional bleeding from the lesion, and there is also a history of speech and chewing and swallowing difficulty with worsening of pain. So there is no history of change in voice, no history of decreased mouth opening, no history of loosening of teeth. There is no history of neck swelling, and there is no history of ulcer or mass elsewhere in the oral cavity. His personal history, there is history of tobacco consumption. He's a tobacco chewer daily for the last 8 years and reformed since last 1 month after the diagnosis. History of occasional alcohol consumption. No history of dentures or sharp teeth. No history of weight loss. No history of breathing difficulty, cough, bone pain, chest pain. No history of treatment taken elsewhere for the present complaints. No significant family history. No history of diabetes, hypertension, TB, asthma, or any other medical disorder. So, in a summary of history, my patient is a 34-year-old male, a farmer, and a tobacco chewer for 8 years, who has been reformed since last 1 month. Is presented to us with a non-healing ulcer over the lateral surface of the right side of tongue, with pain referred to the right ear, and patient is associated with difficulty in chewing and swallowing. So going to the examination, we can see that patient is conscious, cooperative, and oriented with average build and nourishment. ECOG status is 0. His vitals is normal.
Dr. James, can I interrupt?
Yes, ma'am.
Hold on. Dr. Elizabeth here.
Yeah.
So before going for the examination, from the history part, how will you actually, what is in your mind, whether it's an early cancer, you know that it's a malignancy. So from your history part, whether you can infer if it is an early malignancy of the tongue or an advanced, and what are your points in favor of your confirmed stage of the tumor?
Yes, ma'am. So my patient has difficulty in chewing and swallowing, ma'am.
Okay.
And also patient, which indicates that the lesion is actually not a small lesion, but lesion with a significant size. So I will think that this lesion is not an early lesion, ma'am, because of this history of difficulty in speech and swallowing, along with not able to take food. That one history, it will point towards it being an advanced malignancy, ma'am.
Okay. Also the pain and the referred autalgia.
Yes, ma'am.
So, Dr. James.
Yes,
Okay,
sir.
the pain, difficulty in even hypersalivation or drooling of saliva, all those things will be there along with your pain and the referred autalgia. So that indicates that from history itself, you can infer that this patient has an advanced stage disease. Okay, continue.
Yes, ma'am.
Dr. James.
Yes, sir.
One thing which is a common question about this kind of presentation is, what do you think is the reason for the earache?
Sir, so this pain is actually because, sir, the brain receives multiple signals due to this pain, sir, and it gets confused and the pain gets referred to the ear. So how it gets referred to the ear from the tongue is the anterior to the tongue. The pain comes from the lingual nerve and it goes to the auriculotemporal nerve. Whereas in the posterior 1/3, it goes from the glossopharyngeal nerve and efferent pathway is the tympanic plexus. So but the tympanic plexus pain will be a deep-seated pain, whereas from the pain from the anterior part of the tongue will go and it will give a pain in the external auditory canal.
Yeah, it will be just outside the or the medial to tragus cartilage.
Yes,
right?
yes, sir.
Yeah. Another thing that you have mentioned is that this pain is increased on chewing.
Yes,
Why
sir.
is this pain increased on chewing
Sir,
and swallowing?
yes, sir. So there is
Why
an
is it
ulcer.
increasing on swallowing?
Yes, sir. So there is an ulcer in the lateral border of tongue, sir. So when we look at the oral stage of swallowing, what happens is there is approximation of the tongue with the palate. So when this ulcer goes and hits the palate, sir, so that can be one reason for this pain, sir. While especially during swallowing, when the bolus is tried to push from the oral phase to the pharyngeal stage, so that time when the ulcer hits the palate, that could be a reason for the pain, sir. And the tongue movements per se can cause pain, sir.
Okay, good. Any of the panelists want to ask anything more on the history, or should we proceed with the physical examination?
So, Anthony,
James,
since we are talking about pain, since we are discussing about the pain, can
Yes,
you
ma'am.
just tell one or two mediators of pain in the cancer microenvironment? This is just a deviation from this thing, but it's regarding pain. How does this pain occurs? Can you say something about the mediators?
I'm not sure of the medias. I'll read about it, ma'am.
You just read about the mediators of cancer pain like endothelin factor. This is a vasoactive peptide and protease and nerve growth factor. Okay, these are the three mediators. You can just read about it.
Sure,
Just
ma'am,
because
sure.
we are discussing about pain, I thought I'll ask.
Yes, ma'am. Okay, ma'am.
James, did he complain of any swelling in the neck? Because you told it's an advanced disease of the tongue.
Yes,
Any
sir.
history of swelling in the neck?
Yes, sir. So when the patient presented to us, he did not complain, sir. But in the forthcoming examination, our findings will be different. But patient did not complain of any swelling in the neck, sir. There was no obvious swelling in the neck, sir.
Okay, okay.
Dr. Anthony, I have a question.
Yes, sir.
Why tongue lesions are so painful?
Sir, due to the inherent abundant nerve supply of the nerve endings to the tongue, sir. So that is one reason where the nerve endings and go up to the mucosa of the tongue, sir. So that is one reason where pain is more in the tongue compared to the other sides, sir.
No, the right answer is that there is a very large cortical representation from the tongue.
Okay, sir.
So that is why the patient, the similar lesion, if it is present in the buccal mucosa, will not be that painful. If you remember from your physiology pictures, the cortical representation, you see the tongue is represented in a very large area in the cortex.
Okay, sir. Okay, sir. Okay.
Just another point. Before we call somebody reformed from any type of substance abuse, there is generally a required precise time period that is required. So for tobacco, 4 months is not adequate time.
Yes, sir.
And if you are quantifying a substance abuse habit, you should always have some type of quantification that how much was he using with some additive, with some accelerant or stuff. Because what are the, I am sure you would have already read what are the contributing factors to
Yes, sir.
carcinogenesis with tobacco.
Yes, sir.
So,
Yes, sir.
so can you elaborate on that?
Yes, sir, I can, sir. So our patient is a tobacco chewer, sir. So he's been taking 2 packets of tobacco, this areca nut and gudka he used to say. Sir. He's a farmer, sir. So whatever he gets there, he has. And he's an occasional alcoholic also. So, so because of that, he has got this, sir. And he's been chewing for the last 8 years, sir. So sir, you want me to elaborate on the tobacco, on what areca nut like that you're asking, sir,
No,
or
so
only?
the thing is, usually it is important to say whether that he was taking tobacco with lime or
Okay.
just like that. And
Okay.
if he was taking areca nut, he would or could have complained of a decreased oral opening or mouth opening because it can set in some mucosal fibrosis, right?
Yes, sir. Yes,
So
sir.
I think that could have been missed up here and there. But I think we can proceed with the physical examination if the panelists don't have any other question. Yeah. Go ahead with the
Yes.
physical examination.
On general examination, our patient is conscious, cooperative, and oriented with an average build and nourishment. ECOG status is 0. The pulse rate, BP are all normal. There is no pallor, icterus, cyanosis, clubbing, edema, or generalized lymphadenopathy. So this is the picture for the patient. Mouth opening is adequate. So the interincisor distance is 3.5 centimeter. Patient is dented, poor oral hygiene, and it is tobacco stained. Tongue movements, there is restriction. Leukoplakic patches are present on the dorsal surface of tongue. So this lesion is around 4 to 4.5 to 4 centimeter lesion over the lateral surface of tongue on the right side, anteriorly 1 centimeter from tip, posteriorly touching CVP, inferiorly involving the floor of mouth. So this is the actual picture of the lesion. So on doing palpation, I can confirm my inspectory findings. Induration is palpated up to midline, posteriorly just ablating CVP, but base of tongue is free. No other lesion detected in the oral cavity. Skin also looks free. On Hopkins, the bilateral cord is mobile and there is no other lesion seen. So in neck, there is no visible swelling, scars, sinuses, but on palpation, there is a 1 centimeter node in right level 2, which is hard, tender, and mobile. So overlying skin over that node is normal. Systemic examination is clear. So to summarize, my patient is a 35-year-old male tobacco consumer with a 4.5 cross 4 non-healing ulcer over the lateral surface of right side of tongue, involving floor of mouth, abutting midline with reduced tongue mobility with a right level 2 node. So my provisional diagnosis will be a malignant neoplasm of right lateral surface of tongue T4A N1. So or the first investigation.
Hold
Yes.
on, Dr. James. So let us sort of discuss this part of the workup. So in physical examination, this patient seems to have quite a large lesion. So this patient cannot be ECOG 0. He would definitely be symptomatic of these problems, and in all likelihood, the patient would have some weight loss because of reduced oral intake and continued small volume of bleeding from there, right?
Okay,
It is
sir. Yes.
already bleeding in your picture. So it would be probably more appropriate if we label it as ECOG 1. And
Okay, sir.
it would also be reasonable to mention if the patient has some cancer cachexia or some frailty which has developed out of this, because this patient comes out of a low socioeconomic status and has presented relatively late with this problem. And so that should be covered in your presentation. Another
Okay.
thing, you have not mentioned about, I think, the nerve involvement. Do you check for any nerve involvement in a case of locally advanced tongue?
Yes, sir. We can look for hypoglossal nerve involvement, sir. Or when it goes into the base of tongue, glossopharyngeal nerve involvement also we can look for, sir.
So
Or
how do you do that?
lingual. Sorry, sir.
How do you do that?
Sir, we can tell the patient to protrude the tongue out, sir. So if patient's tongue, if ipsilateral on the side of the lesion hypoglossal is involved, the tongue will, if we protrude the tongue, the same side the tongue will deviate, sir. On the side of the lesion, the tongue will deviate. And we can do a gag test and also see if the hypoglossal nerve is intact.
Okay. Panelists, ma'am, if you have any question, Dr. Richa has joined us.
Yes, sir, I'm there.
Okay, sir, Vipin sir. Sir, do you have any
So,
question?
Dr. Anthony, since you have said that, what are the causes of this late presentation in our population?
Yes, ma'am. So
Why
the
these
first.
patients most of like around?
Yes, ma'am. So the first thing is awareness, ma'am. So in our population.
Patients present late.
Yes, ma'am. So the first thing is the patient's awareness that this is cancer. They go to around 4 or 5 general practitioners before coming to a tertiary care center, ma'am. So initially, and second thing is patient's exposure level for this, ma'am. So they to accept that it is cancer and they need treatment. So that part takes time for them to process it, and by the time
the low socioeconomic status right
Yes,
there, and then also the ignorant and illiterate set of people, and then also the tobacco, alcohol addiction, and maybe support or financial support. All these are factors for our people to come late in our OPD. So
Yes,
you should think about all these things. And in this case, actually, whether you said about the dose of invasion in such cases?
ma'am, can you please repeat the question, ma'am? I'm not able to hear you, ma'am.
Whether you will be able to assess
Your voice is breaking, ma'am. I'm not able to hear, ma'am.
clinically the depth of invasion in such malignancy?
Ma'am, clinically there is a crude method. I will try to bimanually palpate the lesion. If my pulp of my fingers are not meeting, then I will think the depth of invasion is more than 1 centimeter, ma'am. But it's a very crude method. If I do it clinically, and it is painful for the patient also. If I try
What
to
do
do
you call it? Depth of invasion, or you
Any
call
lesion
it
which is
something else?
visible only with the depth of it.
Dr. James?
Yes, sir. I call it tumor thickness, sir.
Yeah, why not depth of invasion?
Sir,
Can you
depth
please
of
clarify?
Yes, sir. Depth of invasion is from the basement membrane, sir, and till the lowest point of the tumor. Whereas tumor thickness is from the maximum irregular spot to the maximum depth of the tumor, sir. So when I'm doing it bimanually, I will be able to find out the tumor thickness only, sir. I won't be able to do the depth of invasion.
Okay.
Depth of invasion can only be found in histopathology.
Yes, sir.
Okay,
Yes.
this is a simple answer.
Yes, sir.
James, so how did you call it as T4A?
Sir,
Under what criteria?
Yes, sir. So patient has restriction in tongue mobility, sir, and also the size of the lesion. These two things, so restriction in tongue mobility points towards the involvement of extrinsic muscles of tongue. So because of that, I feel that lesion will be a T4A lesion.
But then that is not included in your staging system, right? So how can you have to actually quantify why it is specifically restriction of movements is not included as a change in the stage to T4. So I think you have to be more accurate.
Okay, sir. Okay.
So Dr. James, going by the size of the lesion and the thickness, you may be able to say that it is a T4 lesion, but T4A will be a difficult thing to limit to. Another thing that you said in your neck examination is that the node is tender. Why do you think the node is tender?
Sir, there could be inflammation also, sir. So because of that, or any infection, because the patient has poor orodental hygiene, sir. So because of that, there can be some underlying infection in the oral cavity, which could also lead to reactive lymphadenopathy, sir. So because of that, there could be pain in the node, sir.
Does this poor oral hygiene has anything to do with the prognosis of the malignancy or progression of the malignancy?
Sir, poor oral hygiene, what happens is, sir, if poor oral hygiene is there, sir, post-op wound healing will be affected, sir. So because of that, what happens is the time to receive RT can get delayed, and that can affect, sir. Wound
There
healing,
is no
wound healing can get affected because of poor orodental hygiene, sir.
Does it contribute to the causation of these problems also?
Yes, sir. It is also a contributory cause, sir. Yes, sir. Poor orodental hygiene is a contributory cause to poor post-operative wound healing, sir.
No, not just post-operative wound healing, but formation of the cancer or the carcinogenesis. Does poor oral
Yes, sir.
hygiene have anything to do with that?
Yes, sir. There is, sir. So presence of a sharp tooth. So is one has been a single sharp tooth is one of the causative agents for causing cancer, sir.
Poor orodental hygiene itself is a risk factor for oral cancer.
Okay, sir.
It's a contributory. And secondly, you're saying that this is an N1 node, and
Yes,
then
sir.
you're saying it is a tender node and maybe inflammatory. So what would you consider it as a metastatic node or inflammatory node, or you want to further evaluate it?
Sir, I'll need to further evaluate it with my imaging, sir. And
But for the time being, you are labeling it as a
N1, sir.
inflammatory. You are labeling it as a metastatic node.
Yes, sir. Yes, sir. Benefit. Yes, sir. I'm labeling it as metastatic, sir. It is on the side of the lesion. The node is on the side of the lesion, and the consistency of the node is also a little hard. So I'm pointing it towards malignancy.
Suppose you do an FNAC in this case, it is a tender lymph node. You do an FNAC.
Yes,
and
sir.
it comes out to be a reactive node.
Okay, sir. I will still go ahead with neck dissection for this patient.
Yes, that is very important. You
Yes,
still
sir.
the lymph node in the primary drainage area, irrespective of any FNAC, or it has to be considered as a malignant lymph node and has to be treated during the primary treatment only.
Yes, sir.
That is important for us. Okay, please proceed.
So investigations, I will first order a cross-sectional imaging with metastatic workup, biopsy, and routine blood investigations. So the MRI which I did was a contrast enhanced MRI. This is an axial T1 contrast image.
Dr. James, please.
Yes, sir.
Please hold on after every step of this thing. For example, you said cross-sectional investigation.
Yes, sir.
Why not a biopsy first?
Sir, the biopsy will cause inflammation in the tissue, sir, and also it will increase the peritumoral edema in the area, sir. So because of that, what will happen is the imaging will overestimate the lesion, sir. If I go do a biopsy, then I'll have to wait for quite a period of time for this inflammation to settle down before doing an MRI. So I would like to prefer to do an imaging before going ahead with biopsy for this patient.
Okay, so what is the average time of reporting of imaging at your center?
Sir, we can get the report. We can get it early, sir. Like in 3 days, sir. Yes.
So, but this patient has presented to you in the OPD.
Yes, sir.
What would you say, that you do a biopsy only after the imaging?
Sir, no, sir.
What do you practically do?
Sir, practically we do the biopsy, sir, because the waiting period for MRI is around 1 to 2 weeks, sir, in our institute. So because of that, we do biopsy first, and by the time the MRI date comes, the inflammation settles down. So we first do the biopsy because MRI also we have a waiting period in our institute, sir. So because of that, we first go in the first presentation, we do biopsy, and then we go with cross-sectional imaging, sir.
First, you do routine blood investigations to see whether the patient does not have any serious problems. If this patient's HB is 6.5, you will not do a biopsy. You go ahead with routine blood investigations, and you can do a biopsy, especially in advanced lesions, because it will not upstage them. It is already a T4, what it is going to become.
Yes. Okay.
So in early lesions, that is going to that may influence a edema being counted as advancement of disease. For locally advanced lesions, that should not matter. And you are anyways, where are you going to take this biopsy from?
From the most representative area, sir.
And is that going to be the edge of the tumor?
Yes, sir. Because the central, yes, sir. I'll take it from the edge of the tumor, sir.
Why?
Because the central, if I take it from the center of the tumor, sir, the chances of it being a necrotic tissue is more, sir.
But why is it that you take it from the edge of the tumor? What is it at the edge that you want in this case?
The
Most representative is any area which is right in the middle of it and is not looking necrotic.
I'll do a biopsy such that there is maximum chance to get the tumor tissue, sir. So, in the center, the amount of the chances of getting the necrotic tissue is more than in the periphery, sir. So I'll take biopsy from the edge, sir.
Can you take a punch biopsy from the edge? Hello? Am I
Yes,
audible?
sir. Yes, sir. Yes, sir.
Can you take a punch biopsy from the edge of a tumor?
Sir, if it is a proliferative tumor, then I will go ahead with punch biopsy only, sir. I can be able to take, sir. If there is a proliferative component in the edge, I'll be able to take a punch biopsy, sir. Yes.
You cannot take a punch biopsy from the edge of the tumor because there will be normal tissue there. Edge of the tumor is important in cases where you need a transition. So the edge of the tumor, you cannot take a punch biopsy. It is not friable. You have to take an incision biopsy there. You cannot take a punch biopsy from the edge of the tumor. So you take a punch biopsy from any area which is looking red and tumorous and not dark and shaggy covered with slough. Any area would be representative enough and friable enough to take a biopsy.
Okay, sir.
You do not need to take a punch biopsy, incision biopsy in this tumor. So you do a routine blood investigation, you do a biopsy. And why do you even need a biopsy? Can you take a sort of a touch smear or a cytology? A lot of screening programs used to have cytology.
Yes, sir.
Can you take a cytology of this?
We can take a smear, sir, but we usually take a biopsy before proceeding. We need a positive biopsy report before proceeding for surgery for this patient, sir, because this patient will be doing a major surgery, sir. So we need to have a proper biopsy report before proceeding to surgery. So I'll prefer a biopsy, sir.
If you have an outside report saying this lymph node is already metastatic squamous cell carcinoma, you will take it as a malignancy or not?
Sir, I will review the slides in my institute, sir. And also, I'll review the slides, sir. I'll tell them to try to get the slides and I'll review the slides and then I'll confirm my findings, sir.
Yes, but otherwise also you should not do a touch smear or a cytology of this because this is keratinizing squamous cell carcinoma and many times it does not give you the requisite exfoliated squamous cell carcinoma cell. So that is why you cannot do a oral cytology confidently most of the time.
Okay, sir.
Okay. So coming to the cross-sectional imaging, please explain what cross-sectional imaging and metastatic workup will you choose and your reasons for the same.
Yes. So this patient, I would like to do a magnetic resonance imaging, sir. Why magnetic resonance imaging is, I would like to clearly see the depth of invasion, the amount of extrinsic muscles of tongue involved, and also the floor of mouth extension and involvement of the neurovascular bundle also. So for all these reasons, I will prefer an MRI over a CT scan. And for metastatic and the which all cuts I will ask for is an axial T1 with contrast, also coronal as well as sagittal. And also I will ask for a stir sequence also I will ask, and also fat suppression imaging I will ask. And for a metastatic workup, for this patient, I would like to do a NCCT thorax NCCT thorax to rule out any distant metastasis for this patient.
Okay. Any of the panelists want to question the choice of metastatic workup investigation? Madam, sir.
James, if someone asks you regarding a PET CT, will you go for a PET CT or you will tell MRI and CT thorax is important? And how will you justify your answer?
Yes, sir. So PET CT, why I will not ask for PET CT is for 2-3 reasons, sir. One, it is expensive, and there are certain indications for which I will use PET CT, sir. When patient is having a tongue cancer with high nodal burden, when there are level 4 nodes involved, in these cases, I would like to do a PET CT, sir. Otherwise, I will go ahead with NCCT thorax also because PET CT by itself is an expensive procedure and waiting period of it can delay surgery, sir. So unless there are proper advanced disease indications, I will go ahead with NCCT thorax only, sir.
Good.
But you are already having a T4 disease. So this is
Yes.
advanced enough.
Yes, sir.
And you also have a nodal disease which is bulky also.
So
by your
node.
own, yeah,
It
but
is
it is
single node,
quite
so
bulky as per your. So, do you have a comparative of CT over PET CT, or is that your personal opinion?
yes, sir. This is what.
Can you quote any studies, James, which has compared CT, like MRI plus CT thorax versus a PET CT?
No, sir. I'll read about it.
Yeah, there is a study published from the Korean group which tells that PET CT does not increase the incremental value of
Okay.
detecting distant metastasis.
Okay, sir. Okay. I'll read about it, sir.
So Anthony, if you have lymph nodes, large lymph nodes or bulky lymph nodes, particularly in the lower part of the neck.
Yes, sir.
So that is probably an indication for getting a
PET CT.
Yeah.
Yes.
So, shall we proceed with the next part, sir?
Yes, certainly.
Hi, please.
So this is my axial T1 with contrast. So as we can see, the lesion is there in the right lateral border of tongue, just abutting midline, involving the extrinsic muscles of tongue in this cut and in this cut. So
what kind of imaging is this?
This is axial T1 with contrast, sir.
How do you know it is T1? Hello.
Yes, sir. Yes, sir. Sir.
Yeah.
Sir, the water is bright on T2, sir. In this, the fluids, the cranial fluid and everything is dark, sir. So with that, I will know it is a T1 contrast image, sir.
And how do we know that it is contrast?
Sir, the image lighting up, we can see, sir, that it is a contrast, and the blood vessels also are showing enhancement. So in that, I will say that it is a contrast image.
Okay. So what is the advantage of this view over a stir image?
Sir, stir image will show us peritumoral edema, sir. But exact extent, so the stir image has the advantage that it can separate what the tumor is and what the peritumoral edema is. But this T1 contrast image shows, will give more information regarding the extrinsic muscle of tongue involvement, the neurovascular bundle involvement is better seen in a T1 with contrast image. Whereas to separate the tumor from a peritumoral edema, I will use a stir sequencer.
You cannot actually differentiate peritumoral edema from the tumor in the stir image. You can appreciate anatomy better in T1.
Yes,
and
sir.
This is a fat suppressed T1 with contrast.
Yes, sir.
So stir gives you the abnormal area, and this will help you define by summation of the two in your own sort of clinical acumen that till how much is the edema and till how much is the tumor. So if stir could give you how much is the tumor and how much is the tumor edema, then you don't need any other thing. Then you don't need the tumor edema also. So that helps delineate better. It's something like it picks it up better. But this will
Okay.
help you define the anatomy better overall.
Okay, sir.
Panelists want to add anything, madam? Sir?
Actually, what are your radiological signs of perineural invasion?
Ma'am, per se, so perineural invasion, so we have, it is more seen in zone 2 and zone 3 than in the primary site, ma'am. So if we are commenting on perineural invasion, there should be brightening of the V3 branch of the trigeminal nerve, ma'am. And then fat stranding in the skull base area is one area where which we can say that perineural invasion is there, ma'am. And also brightening of the nerve between the pterygoid muscles is one criteria, ma'am. So these are so to comment on perineural invasion in MRA, we better to see the zone 2 and zone 3 than the primary site to see, ma'am. Otherwise, these are the things I will use, ma'am. Otherwise, to see the neurovascular the nerve in coronal section, it's in axial T1 contrast in the tongue. It's difficult, ma'am.
Okay, good.
So can we proceed to the next part?
Yes, sir. So this is the sagittal image.
Yeah.
And NCCT thorax, which showing no distant metastasis. Patient's biopsy is a moderately differentiated squamous cell carcinoma. The routine labs were all within normal limits. So my surgical patient is anesthesia fit also. So my provisional surgical plan will be a near total vasectomy with bilateral neck dissection and a free flap.
What is your treatment plan? Not the surgical plan. What sort of treatment option you?
Yes, sir. So the ideal treatment plan for this patient will be a surgery followed by adjuvant therapy.
So primary surgery followed by postoperative adjuvant.
Yes, ma'am. Adjuvant treatment based on the biopsy report.
Is there any sign of inoperability here? What are the signs of inoperability?
Yes, ma'am. So before subjecting this patient to surgery, I would like to do a examination under anesthesia, ma'am. So in this examination under anesthesia, I will most importantly look at the posterior extent of the tumor, ma'am. If the tumor is reaching the vallicula or going beyond it, then the lesion will be deemed inoperable, ma'am. And also the inferior extent, I will see the relation of this tongue tumor to the hyoid bone, ma'am. So I should get planes between the tumor and the hyoid bone to deem it operable. So if there is a lesion which is going and involving the hyoid, then also it becomes inoperable. And also in MRI, I will look for the parapharyngeal space involvement. If parapharyngeal space is involved, then the tumor is inoperable. And also these are the things I will see, ma'am, for checking for operability. So per se to make it frank inoperable.
So suppose if the lesion is up to the vallicular area, is there any role for neoadjuvant chemo or
Yes,
are you straight away for going for primary?
No, ma'am. If a lesion is reaching up to vallicula, I would like to give 2 cycles of NACT, and I like to give NACT and then reassess the lesion, ma'am.
What are the advantages of giving NACT?
Ma'am, one thing is we'll be able to get good margins, ma'am. So the size of the lesion, if it reduces after NACT, so the lesion will be operable, and we'll be able to save some amount of base of tongue, ma'am, for the patient. So to give him whatever quality of life we can give, ma'am. So that is one advantage. That is advantage.
Can you tell 1 or 2 trials in the NACT in the resectable oral cancer patients?
Yes, ma'am.
Major trials?
Yes, ma'am. So there is a study from India, ma'am. So, ma'am, yes, ma'am. So this Lisitra et al. Had done a publication, ma'am. So in that they gave chemotherapy. They separated it into 2 arms and they gave NACT surgery and an upfront surgical arm. But in that finding, they found out that NACT is more in the terms of it not much difference in survival, but there is difference in preserving the mandible, ma'am. So NACT was able to preserve the mandible more, ma'am, in Lisitra, the study done by Lisitra et al.
So in Lisitra trial, what percentage had a complete response? Pathological response?
Around 50, ma'am.
Approximately 33%, I think, just for that. So what do you mean by this good pathological response? How does the pathologist comment it as good pathological response?
Ma'am,
Because
that will
that
be.
good pathological response means the patient has a good outcome, right?
Yes,
So
ma'am.
that's a surrogate marker. By giving a neoadjuvant chemo, if the patient has a good outcome, a good pathological response, the prognosis is going to be good. So how does they comment it as a good pathological response? How many or what percentage of viable cells should we see?
Ma'am, there are three responses, ma'am. One is complete, another is partial, then stable disease and progressive disease, ma'am. Complete response is where there is no residual tumor present, ma'am. Partial response is when there is a greater than 20% response, ma'am. And progressive disease is when there is progression of more than 30% from pre-NACT. And stable disease is neither complete response or there is response, partial response.
Yeah, okay. Also, less than 10% viable tumor cells.
Okay.
That is, yeah, that indicates a good pathological response. So, so you said about Lysitra trial. Any other major trial in the resectable oral cancer about
Yes, ma'am.
neoadjuvant chemo?
Yes, ma'am. Yes, ma'am. Done by Dr. Devendra Chakar et al, ma'am. There is one NACT trial, ma'am, published from TMH, ma'am. And
Also Song et al.
Song et al. Yes.
Okay, yeah.
James, what was the mandibular preservation rate in Chaukar's study? It's 47%. Yeah, you can go ahead.
Okay.
So,
Dr. Anthony, which regimen is followed if you plan to give new adjuvant chemotherapy?
Yes, sir. So we like to give cisplatin with 5-fluorouracil, sir. 3 cycles. Sir, we like to give cisplatin, 5-fluorouracil, and docetaxel, sir.
Yes. Okay. Okay. So that is given in 3 cycles.
Yes,
and
sir.
then you reassess the response. And what is the disadvantage? Why don't we give in all the advanced cases? What is the disadvantage of giving new adjuvant chemotherapy?
The first one is the toxicity, sir, which comes with drugs. So the drugs per se, cisplatin has its renal toxicities. There, 5-fluorouracil has its own complications. Docetaxel has a hypersensitivity reaction as its complications. So in trials published as TAX 323, TAX 324, we could see that the complication rates were also substantial in with the response rates, sir. So because of that. So that is one thing, sir. One is the toxicity which comes with it, and that can only per se delay treatment, sir, if patient has the toxicity in this. And one more thing is, if the cancer progresses with this chemo, sir, we don't have any other option for the patient. Patient will straight away go into a palliative setup, sir. So the most important thing is it gives we lose a backup option, sir, if we give NACT upfront.
Okay.
Well,
And it becomes a
tell the
triple modality
dosage?
treatment.
Sorry, ma'am?
It becomes a triple modality treatments. You would have used all the modalities in this particular patient, increasing the toxicity.
Yes, sir.
Can
Yes,
you also mention the dosage of all these 3 drugs?
Yes, sir.
Docetaxel, cisplatin, and
Yes, ma'am.
5-FU?
So cisplatin is a 3-weekly regimen, ma'am. So 3 weekly, if we are giving, it will be 100 mg, ma'am. 5-fluorouracil total will be 1000, ma'am. And docetaxel, I'm not sure. There are 2 regimens for cisplatin. One is
You can
100
just
and
remember it as 75 milligram per meter square cisplatin and docetaxel, and 5-FU 750 milligram per meter square. That is over 1 to 5 days you have to give. Okay.
Yes, ma'am. Yes, ma'am.
So, Dr. James, the reason
Yes.
why we don't give NACT is because there is no OS benefit if it is
Yes, sir.
operable.
Yes, sir.
It's not because of the toxicity. We give neoadjuvant chemotherapy in so many other cancers, accepting those toxicities because there is a significant OS benefit, overall survival benefit. NACT in head neck cancer is mainly done to reduce a borderline resectable to a resectable stage, or for the purpose of mandibular preservation.
Yes,
So
sir.
it does not achieve OS benefit.
Yes, sir.
So that should be your answer rather than a so-called a logistic answer that it will exhaust so many modalities and this and that. If it can help the patient recover better, then why not exhaust all of them right now?
Okay, sir.
So there is no incremental benefit of that thing. So how do you define borderline resectable tongue?
Yes, sir. So borderline resectable tongue are lesions which are reaching up to the valvula, sir. So that is
What
one
if it
borderline
is
lesion.
involved? If
Sorry?
the valvula is involved, will you give NACT?
Yes, sir. If lesion is reaching up to valvula, I will give an ACT,
No.
sir. Yes.
If the valvula is involved, the lingular surface of epiglottis is involved, can you give NACT?
Sir, usually we don't give, sir. The indication is, as paper suggests, that lesion reaching up to valvula is one indication for NACTs.
And other ones?
Sir,
Other
lesion loss of planes with hyoid, sir. Tongue malignancy with loss of planes to hyoid is also one other indication which we use for NACT, sir.
So the idea is you give NACT when you won't get margins.
Yes,
If you
sir.
can get margins, you resect upfront.
Yes, sir.
If it is already involving the hyoid, you cannot make that thing resectable by giving NACT. Anyway,
Yes.
so what are the types of glossectomies that you know of?
Yes, sir. So the classification is by Ansari et al., published in 2019. So type 1 is just
Before that,
white.
Anthony, for neoadjuvant chemo.
Sorry, ma'am.
Yeah, before finishing up with the NACT, can you just
Ma'am, I'm not able to hear you, ma'am. Sorry, ma'am.
enumerate any predictive biomarkers of NACT? Neoadjuvant chemotherapy, any predictive biomarkers? About some predictive biomarkers of neoadjuvant chemo? Yeah, just read about it. Grade,
Yes.
mitotic index, apoptotic.
Okay, ma'am. I'll read about it, ma'am. Yes, ma'am.
Index key 67, B50. Yeah, okay.
Okay.
James, I think we are running short of time. So can we discuss indications for adjuvant treatment and
Yes, sir.
then complete the presentation?
Yes, sir. So the indications for adjuvant treatment for this patient will be lesion being a T4A lesion, sir. That is one indication. Then other indications will be an N plus next, sir. Even if one node is involved, I will go ahead with adjuvant treatment for this patient. And if there is extranodal in extension or I'm going close on my margins, if positive margin comes, then I'll go for CTRT, sir. Otherwise, other indications for adjuvant RT will be the LVI PNI involvement, the PNI involvement, the depth of invasion also can be used as an indicator for post-operative radiotherapy, sir.
Well, in this case, it is quite obvious that it's a T4 lesion, right?
Yes, sir.
So that will be the indication, I
Indication
think.
for adjuvant.
Yeah.
Yes, sir.
Dr. Anthony, which flap do you want to use for reconstruction in this case?
This patient is a young patient, sir. So it's a 34-year-old male. So I would like to, and we are going to do a near total glossectomy. So looking at his build and nourishment and everything, I would like to go for an anterolateral thigh flap for this patient. And also to improve the bulk, I'll request my plastic surgeon to take, in addition to the skin, a vastus lateralis also to give him that bulk.
Okay. So is there any estimate means is there any way to define the reconstruction in a preoperative period, like the amount of tissue you are going to resect and
Yes,
the flap
yes,
that you are going to use?
Yes, sir. So less than 30% if tongue is resected, sir, I will go ahead with primary closure. When so reconstruction comes into play when I remove more than 30% of the tongue, sir. So when I do a near total glossectomy, so I would like to give this patient a flap, which will, because we will be going and taking the base of tongue from one side only. The opposite side base of tongue is going to be preserved, sir. So if looking for a good swallowing function also for this patient, I would like to go for an ALT flap only, sir. So when we go for near total glossectomy, free radial forearm free flap will not be able to, because it is a thin and pliable flap, it will not provide the bulk which needs when we do a near total glossectomy. So when we do a hemiglossectomy defects, then I'll go ahead with flap, sir. Otherwise, for near total glossectomy, we'll go with ALT, sir.
So
James, the time is actually up, James.
Okay, sorry.
So
we
the
will
organizers have requested.
We will just finish it up, sir. I just want to add one thing, that there was actually a standardized meta-analysis on this thing, that if it is less than 20%, it is usually a primary closure. 20 to 40% is no man's land. Nobody has commented upon what would be the ideal reconstruction. And for more than 40% generally requires some flap or the other.
Yes.
This
Okay.
30% that you are quoting is probably an Indian study only. And but that is one big international study which has given those kind of numbers. So thank you everybody for joining here and giving us this opportunity. I would hand over this session to the organizers. So you are all very well prepared. So you definitely, you're in your assessment, I think you would be a pass with the flying colors. So congratulations on your preparation. Sir, I think you guys should also give him an assessment. Vipin sir and ma'am.
Yeah, Anthony, you did very well. Excellent. Thank
Thank
you.
you. Thank you, ma'am.
Okay. Thank you.
Very well
Excellent
done.
presentation, Dr. Anthony, and my congratulations to you and your mentors also.
Thank you, sir.
Yes.
Mansi, you can take over, I guess.
Yes, sir. Thank you very much, James and the panelists for this detailed and comprehensive discussion on advanced oral cancer patient. So moving on to the last session for day one, which will be a panel discussion on landmark trials for oral cavity carcinoma. The expert panelists for this session are Dr. Arvind Krishnamurthy. Sir is Professor Surgical Oncology at Cancer Institute, Adyar, Chennai. Dr. Pankaj Garg. Sir is Professor and Head Department of Surgical Oncology at Sri Guru Ram Rai Institute of Medical and Health Sciences, Dehradun. Dr. Senthil Kumar Ravichandran. Sir is Director of Surgical Oncology at MIOT Institute of Cancer Cure, Chennai. Dr. Arjun Singh. Sir is Assistant Professor in the Department of Head and Neck Surgical Oncology at Tata Memorial Center, ACTRAC, Navi Mumbai. And Dr. Shwetab Sinha. Sir is Assistant Professor in the Department of Radiation Oncology at Tata Memorial Center, ACTRAC, Navi Mumbai. This session will be conducted by Dr. Poonam Joshi. Ma'am is Professor in the Department of Head and Neck Surgical Oncology at Tata Memorial Center, ACTRAC, Navi Mumbai. I request ma'am to kindly take over for this session.
Thank you, Mansi. I think the sessions have been great discussions by all the panelists as well as the speakers. So this is the last session. We'll be wrapping up fast. Anyways, we are ahead of time. So not able to move it. Okay. So this is basically a landmark trials for oral cancers. When I thought about the topic, I thought it will be easy to do. In fact, when I started making the slides, I realized it will be difficult to do it as a panel because, so we'll go into that. So let us see what are landmark trials. So a landmark clinical trial is a trial which has a sustained or important impact on clinical practice. It basically is a trial which causes a paradigm shift in the medical practice. It provides answers to the critical questions which we deal in our medical management day to day, and usually it is given as recommendation after discussion in multidisciplinary panels. So that usually is what our landmark trial is. So we know that there are various levels of evidences. Level 1 to level 5. Usually level 1 is the best level of evidence, which includes the systematic reviews and the meta-analysis, and followed by the randomized control trials, cohort studies, case control studies, case series, and then usually the expert opinion, which comes at the bottom of the pyramid. So just a disclaimer that even though I have written oral cancers, I will be excluding the cutaneous lip here. As I made these slides and I realized that the discussion is going to be very vast, it's a very big topic. And in fact, we can include only few of the topics which would be here the role of definitive radiotherapy in oral cancers, margins of resection, and role of frozen section. So I have tried to include the landmark studies or the seminal papers, but few of the studies may not be that well quoted, but they are relevant to a great extent. So as we know that the treatment for oral cancer, if you go into history, that dates back to 3000 BC, the era of the Egyptian culture. That civilization shows us that it started long time back. Then came the era where by the John Hill that we came to know, okay, there is association of oral head neck cancers with tobacco. As we can see in this the chart, there was then basically we come to the surgical part, the neck dissection as evidenced by George Cryle that came in 1950, then the chemoprophylaxis, and now is the era of the personalized medicine, mainly in the form of the various types of the immunotherapies and the targeted therapy. So we can't do any discussion or we can't start it without the mention of the paper by the Slaughter, the Denley Slaughter, which is on field cancerization. This was a very good concept. Good means it was very important concept, which was given by Slaughter long back in, I think, 1950s. And this was basically, he gave the concept of multicentricity. That is the multicentric origin of tumor through the process of field cancerization, as these patients are exposed to various kinds of carcinogens, mainly in the form of tobacco. So as we know, primary surgery is considered the standard of care for early oral squamous cell carcinomas and is the preferred treatment modality. Radiotherapy is also recommended as an alternative treatment. So coming to the first point, that in this era, is there still role of definitive RT in oral cancers? So if we see this NCCN guidelines, we can see that definitive RT is one of the treatment still for early oral cancers. So with this, we come to the first question, that for treatment of oral cancers, is there still any role of definitive RT? So I would request any of the panelists to please start with the discussion. I would ask Arvind sir, if sir, are you there?
Yes, Poonam, I'm there. I'm traveling, so I'm not sure how my signal is, but I guess since I've already committed to it, so it's gone a little late than expected, but I will just give some of my perspectives.
Thank you, sir.
Can you hear me well?
Yes, sir. So is there any role of definitive radiotherapy in this era of free flaps, good technologies? We have, what do you suggest, sir? What is your practice or what is your suggestion?
Right. There are two things. One is, of course, evidence, what we have. Evidence in the form of outcomes. Essentially, we have some little randomized control trials are there. There are a lot of retrospective data, and there's a lot of other NCDB meta-analysis is also there. There was a small randomized control trial by Gopal Iyer's group in Singapore that clearly said that use of radiation therapy in the management of these cancers is detrimental in the DFS and all other outcomes as well. There are a couple of other trials that have suggested equivalence, but by and large, the evidence as such is sort of is less, is not that robust. The meta-analysis of NCDB clearly said also again it favored surgery. So by and large, I think as you rightly said in the slide that's been projected, because surgery is easy, surgery is fast, both in the early and the advanced stages as well. I'm talking about more so in the early stages. That's what I think you're referring to, the definitive radiation therapy. When you talk about definitive radiation therapy, we talk only on the early stages. So it is something that, so we tend to do the, surgery if the other aspect is, considering that survivals are maybe slightly better. The other is with regards to the function and the cosmesis. And so we would reserve radiation therapy generally for patients who are unfit, who are unwilling, or in which we feel that this act of surgery itself could be cosmetically mutilating. For example, tumors that are close to the commissure, extensive surface lesions in the lip, and sometimes some of the lesions in the palate. So these are the only conditions wherein we would sort of, even though it's a fit patient, there could be a consideration for radiation therapy, and of course, it can be given by two means. Either it could be an external beam therapy or it could be brachytherapy. I think I will stop at that and in the interest of time.
Thank you for the great comments. So, Dr. Shwetab, you are there. Dr. Shwetab is radiation oncologist with us. So, Shwetab, like we can see, these are not the landmark trials, but there has been a lot of data. Even recently in 2020, also I was going through the articles. So, if you see that Cohen, Stenson, so they say that okay, there is overall similar survival or progression-free survival. The other study says no, surgery is better. So, what is your take on that?
Thank you, Madam, for first of all for hosting this excellent conference. So definitive radiotherapy can be divided for oral cancers. One, when we are talking about early oral cancers, I think most of us will agree that for certain proliferative lip tumors and hard palate tumors, brachytherapy cancer can be considered. I think in well-selected patients, they yield good outcomes, and that is pretty much an established fact. For advanced tumors, as Arvind sir was also mentioning, there is a trial by Gopal Iyer sir from Singapore. They reported it in 2015, the long-term outcomes and the survival difference was huge for oral cavity cancers. I think it was 60% versus 20%, although the numbers were less. Having said that, what has happened simultaneously when, as compared to, let's say, about 15-20 years ago, which has impacted our outcomes is that on one side, definitely the techniques of surgeries have improved, the techniques of reconstruction have improved, but side by side, the technique of radiotherapy also has improved. I think most of us now, if we are looking at a young, fit patient who for some reason we are not operating, either because of the surgical extent of the disease or because of other medical comorbidities, which precludes, let's say, anesthesia. I think what we used to call, let's say, 10 years ago or 15 years ago, that if you can't do surgery, it is palliative. I don't think that is true now. I think in well-selected patients, even if we are not able to do surgery in advanced tumors, if we select our patients well, who don't have bone involvement, who are young, and otherwise fit, or even old but in good performance status, there is an option of selecting patients on the basis of neoadjuvant chemotherapy. That also option is there. And then if you can do a good definitive CTRT with IMRT and other modern techniques, including proton therapy, you may get survival outcomes of 5 years, 40, 45. That's what the 2020 paper shows. And that would be my take on it. Surgery, definitely the first choice. I think there is no doubt about it. But in well-selected patients where surgery is not considered, even in advanced tumors, you can do definitive CTRT with acceptable outcomes in today's day and age.
Yeah. So thank you, Dr. Shwetab. So I think this is the only randomized trial which Dr. Shwetab just mentioned, which actually compares, this is the randomized trial, which compares the surgery with concurrent chemoradiotherapy. And we see that, in fact, in oral cavity cancers, the survival was definitely much, much better if you compare it with the concurrent chemoradiotherapy group. If you can read the third line, you can see that the 5-year disease-specific survival rates were 68% for surgery versus 12% for concurrent chemoradiotherapy arm. And this was a randomized trial. Around 60 patients were in the each group. And you can see, in fact, for the maxilla, if you see the last line, the survival for maxilla in the concurrent chemotherapy arm, as per the trial, was almost 0% after 5 years, and it was 86% in the surgical arm. So this was the only study, and it gives us a good idea that for the advanced oral cavity cancers, when they are operable, I think still surgery would be the way to go. And so after this is another trial by the Ellis. This is not a randomized trial. However, I included it because it has large number of patients. This is a national cancer database data of 20,779 patients from American Medical Association. And here also the similar findings were there, that the 5-year overall survival was 71% in primary surgery arm versus 36% in the radiotherapy arm. And in fact, the primary radiotherapy arm, even though the number of patients were only 5%, 95% of the patient, they received surgery only, and 5% received primary RT. In these patients, the mortality was higher. In fact, it was 3 times higher as compared to the surgery arm. And if you see over the years, this number of patients who are getting primary RT has actually come down as compared to the number of patients who are getting primary surgery. So I think coming to the just small paper, this is a very small study. I thought we'll include the unresectable patients also. And this was just 24 patients. It was taken and it was seen that the patient where unresectable tumors are there, can we give CT-RT? So we just saw that, okay, again, the median survival, if you can see here, is not great. It comes around 6 months only. So coming to this, I think this message would be here is that the surgery is the primary treatment for early and advanced resectable oral cancers. And for the borderline and unresectable oral cancers, definitive RT may provide limited symptom and disease control. And I think we are not going to discuss about the neoadjuvant chemotherapy here, but still it is a very, I've not written chemotherapy. So neoadjuvant chemotherapy is going to be a valid option in these cases. Definitive radiotherapy may be offered to selected patients like Dr. Shwetab just said, that can be in cases where it is medically inoperable or refuse surgery. And even with the advent of better techniques, now we have even the proton therapy, which is highly specialized therapy. Then with the IMRT techniques, the IGRT techniques, in fact, these patients can be treated reasonably well with good outcomes, as well as the less the post-RT side effects. So coming to the next topic, which is the margins of resection. So as we all know that the pathological margin assessment is an essential component of surgical management of oral squamous cell carcinoma patients. So why do we need to assess margin? This is very important. And so we all know that it is one of the most important prognostic indicator in treating the head and neck cancer patients. And the most important part here is going to be that it is the only modifiable adverse prognostic factor. So this is the only factor which is in the hands of the surgeon where it can make a difference. We know that positive margin is associated with decreased survival and increased locoregional recurrence. There is enough of data, numerous load catering data showing a big difference in the survival between the two. And this is a seminal paper, I would say. This is from the loser, where we get that the positive margins, they really impact the survival. So this was way back in 1978. And they have beautifully described how do you need to process the specimen as well. So here you can see how they have described as positive margins. They have described the positive margins as if the margin closeness or is the tumor from the margin is within 0.5 centimeter. That is if there is any pre-malignant change, or there is in situ cancer, or there is invasive microscopic cancer at the margin. And all these they considered as positive margins, and they had poor survival as compared to the negative margins. So as we know now, it is accepted by all over world, by the Royal College of Pathologists, or you see it NCCN guidelines, you see American Group of Pathologists. Everyone accepts more than 5 mm or up to 5 or more than 5 mm is the clear margin. But recently there has been papers one by Baswa, another by Taché, and another by the Zenoni. So they have described various margins. Like, in fact, these papers have said that even a margin of up to 1 mm can be considered as free. They have shown almost same locoregional control rates. This is again a trial by Zenoni from the MSKCC group, and they have shown that the margins for tongue cancer can be also up to 2.2 millimeters, as we are saying that 5 mm is a clear margin. So what is your take, Dr. Pankaj, on this? That is it a time that we redefine our clear margins?
Thank you so much, Dr. Poonam, for inviting me for this. The first thing that I would like to start with is
for all people, that we should understand that every randomized trial has an expiry date. I do not know who quoted this, but it was a wonderful statement that was made. The trials which were done 20 years back or 30 years back may not hold value in today's time, and that we have to understand. For example, Dr. D. Cruz, the highly quoted randomized control trial published in 2015.
Sorry, Dr. Pankaj, sorry to interrupt you. I think I can not hear you very well. Sorry if I'm the only one. Yeah. So if you could be a bit louder. Yeah.
Am I audible to others?
Yes, better.
Yeah, so what I was saying, so there was a minor randomized control trial published by Dr. D. Cruz in 2015 from Tata Memorial Hospital, where he said that the wait and watch modality is not good for a clinically N0 neck, and we have to go elective neck dissection. And now we are going a step ahead, and we are discussing about the sentinel lymph node biopsy in clinically N0 neck. So things are changing, and that we have to understand. So this is in context of the randomized control trial. Secondly, you said about the role of radiation, so that redefines clear margin. Now, what we are seeing in today's time, when we are giving neoadjuvant chemotherapy, we are seeing an excellent response rate to the tune of 60 to 70%. And 20 to 30% of the time, we are having a absolutely complete response where we cannot even identify the primary issue. Now, what has been the classical teaching is that you have to go by the pre-NECT margin. Now, in a patient who has undergone neoadjuvant chemotherapy, when the primary tumor is not or is hardly visible, if I go back and if I go by the pre-NECT margin, it would be a too morbid surgery. So this is very difficult to digest. So what we are going is relatively, we are definitely not going like a pre-NECT margin, definitely less, but this has always been a confusion. Now, what I want to put forward here, one more point there, we were discussing a randomized radical RT. One of my radiation colleagues in MPT always says this. When you remove these tumors, you do a surgery in these patients, the tumor is hardly visible. There is usually a pathological complete response. So why not to give even a radical RT to these patients? Why to do surgery? So you see, there are a number of questions which are coming up because of an excellent response of NECT. As on today, the margins, the classical theory of going a pre-NECT margins is difficult to digest. And what we are at present doing is somewhere in between. So that would be my take on it, Dr. Poonam.
So thank you, Dr. Pankaj. I think Dr. Arjun, would you like to comment on this question? Would you think that it is high time that we redefine our clear margins from 5 mm to lower like 1 mm or like 2.2 mm or 3 mm?
So firstly, thank you, madam, for organizing this and inviting us. I think, madam, it's very important to see when we say evidence, what evidence is there and what quality of evidence that we are talking about. All these studies that talk about redefining margins or rather making them less, they are all retrospective studies. And let's say I am a group that performs surgery where my average margins are, 2 centimeters. And someone else has an average margin rate of 0.5. Now, if you see, and if I analyze my data that's available to me, I will get a larger margin distance. And if someone else who's repeatedly doing lesser margins or rather shorter margins, they will get a slightly smaller rate. Now, so it's very important when you see this. Secondly, all of these people who have done these studies have always aimed for a clinically discernible 1 centimeter margin intraoperative. So you may have got aiming for 1 centimeter and you may have ended up with 2.2 centimeters. But your aim as a clinician, as a surgeon in the OT should always be clinically 1 centimeter discernible margins from the likely tumor. So I think possibly all of this evidence can be taken with a pinch of salt. But personally, if you ask me, I don't think I would change my practice based on this evidence.
Right. So I think the evidence says the same which Dr. Pankaj and Dr. Arjun said, that see, these all studies are mainly retrospective studies, and they have taken mostly the archival specimens, and then they have seen the margins. The other important point is that many a times these margins have been taken from the defect. And then they have seen, okay, this margin is only 2.2. This may be not the right way to do it. And many a times when the margins have been closed or the closed margins, they have given even the adjuvant RT. So I think still we don't have very good evidence to say that the lesser margins, less than 5 mm, are the right margins. We need better designed prospective multicentric studies which can redefine our clear margins. And till then, more than 5 mm margins are clear margins. So I think that is a take-home message with this discussion. So any one of you practice the defect-driven or the patient-directed margins? Dr. Senthil, you are there? So anyone else? Dr. Pankaj, Dr. Arvind?
Yeah.
The defect-driven margin may not present correctly. So
Sorry, Dr. Pankaj, we can't hear you very clearly.
You're not audible.
You're not very audible. Sorry.
Dr. Poonam, am I audible now?
Yeah, it seems better.
I didn't get that. Could you try again?
Dr. Poonam, am I audible?
Yes, yes. Now very
Doesn't
fine.
look
Yes.
like you have an app named Poonam Mumbai Indians Audible. If you'd like.
Yes, please go ahead, Dr. Pankaj.
Yeah, am I audible?
Yes, yes, you are. Please.
What I was saying that we did do a study and find out that the defect-driven margins do not represent the margins clearly. So as an institutional policy, we go by the specimen-driven margins and not by the defect-driven margins.
Correct.
I agree. I think multiple studies have shown that specimen-driven margins are the way to go, and defect-driven margins may actually underestimate. And there are studies that show that the outcomes are also not that great. So I think you'll have to go for a specimen-driven margin, and agree with the larger point that the message has to be loud and clear, that it has to be more than 5 mm margin. Of course, in many other subsites, the concept of margin is being redefined, but at least in head and neck squamous cell carcinomas, I think the message has to be loud and clear that we aim for a centimeter, and it has to be more than 5 millimeters to label it as a clear.
Correct, sir. I think so. I think we already, both the panelists already said the same points, that the specimen-driven margins usually they reflect the better and the accurate margins, and they better predict the local control rates. In fact, the NCCN guidelines also currently recommend that the evaluation of margins on frozen section should be mainly based on specimen rather than the patient-directed or the defect-directed sampling. So try to take always the specimen-driven margins. That would be the take-home message here. So I think there is this survey by Mustafa Bulbul, which was published in 2021. And they saw that AHNS members, it was like around 185 doctors, they gave their answers to the various questions. And the interesting thing was that the same we got the information that they all preferred a specimen-based approach, and more than 5 mm microscopic margins were considered as the clear margins. So I think that jury is out on this, that the specimen-based approach and more than 5 mm margins are the way to go still. So coming to this next question, that how do we achieve the gross or the surgical, what gross or surgical margins should we aim for to achieve the clear margins of more than 5 mm? I think partly we have discussed it. So I would request the panelists to let us discuss it on the line of mucosal margin, deep margin, and the bone margins.
So what we believe is a 1 centimeter gross margin that we take, because by shrinkage and later on it may shrink to 5 mm. So in order to achieve a 5 mm microscopic margin, we take 1 centimeter macroscopic gross margin.
Correct. So I think we have these, again, very important papers which are from...
And Dr. Poonam, I would like to add this here. It has to be a 3-dimensional margin.
Right. Correct. So that's why I've written all the 3 margins, which is the mucosal margin, the deep and soft tissue margin, and the bone margin. And how do we do or how do we achieve clear margins for all these three set of margins. So because it's not the only margin, the mucosal margin. So for mucosal margin, usually the achieving the more than 5 mm margin is the easiest. And we can see this study, the first study by the Johnson, one of the important paper by Johnson, though it was done on dogs, but it gave us a good idea. Okay, if you achieve a 8 to 10 millimeter of margins, you can achieve a 5 millimeter pathological margin. Then this paper by Mistry et al. From Tata Memorial Hospital, this was on oral cavity cancer patients, and they took tongue and buccal mucosa patients, and they saw that there was mean shrinkage of around 22%. So, so this gives us a good idea, which Dr. Pankaj already said, that so as to achieve a 5 millimeter margin, your gross or the surgical mucosal margin should be minimum of 8 to 10 mm. So coming to the next topic, so what should we do for the deep margins? Because deep margins usually are more difficult to take. Like we said, mucosal margins can be easily seen and can be visual, can be palpated also. Resection of the deep margins usually is limited by the anatomical constraints, like you see in the oropharynx or retromolar trigone area. Usually the features like lymphovascular invasion and the perineural invasion, it allows for the deep infiltration of tumor, and these features are usually unrecognizable intraoperatively or by the visual inspection or palpation. So I think and we know that deep margins are usually the margins which come positive, and they are associated with the poor survival. So in your practice, Arjun, what do you follow so as to achieve good deep margins? What would be your message to the students?
I think the first thing, madam, is it should be a clinical radiological assessment that you should do. So sometimes, in the radiology, you can also see tumors might not be pinchable clinically. And in the radiology, you might see tumors which are more infiltrative. So your decision on a margin or extent of surgery should be based on your findings intraoperative, that is your 1 centimeter clinically discernible, as well as what features you see in the radiograph. Now, third dimension is a very, very important aspect as far as tumor resection is concerned. And if you do need to consider certain anatomical barriers such as the periosteum, or if you need to resect bone or soft tissue lateral to the tumor, then I think it's better to err on the side of safety since we are doing such a extensive resection and we have the support of good reconstruction.
So I think I completely agree with Dr. Arjun. One of the most important point is going to be your proper clinico-radiological assessment, palpation of the tumor, and then using liberally the investigations like MRI available with which you can assess the depth of invasion, perineural invasion, or the extent of bone marrow involvement. You can use CT. I think all of us use it for the cortical bone erosion. And naturally, your experience is going to be always important, especially for the deep margins, where your thorough knowledge of anatomy, the perioperative identifications of the structures, muscles, is going to enable you to get better deep margins. So these are few of the points which will help you to get the good deep margins. So coming to the bone margins, how do you assess bone margins? So anyone, Arvind sir or Senthil is there. So is there how do you decide for bony margins? One is we see it on CT, the cortical erosion and the bone marrow erosion. So do you decide for some margins? You take the 1 centimeter margin, or how you go ahead with the bone margins? Dr. Pankaj?
Ma'am, as it was discussed earlier also, it has to be a clinical and radiological assessment. So we do a radiological assessment properly preoperatively to decide about the margins. And the second thing, we also always take the help of a frozen section examination on table intraoperatively to decide about the margins and whether the further revision is required or not.
Right. So I think that clinical, please go ahead.
Yeah, I think Poonam, I think all points have been well said. I think for bony margins specifically, we look into the CT. Sometimes MRIs can sort of overestimate the extent of the bony margin, so one has to be really careful while doing that. It is better to rely more on the CT, and of course, as importantly as was said, on the clinical palpation aspect as well. Maybe with regards to bone margins, we go about a centimeter and a half to little around 2 centimeters to get that margin. Deep margin, as was said, I think one has to be very, very careful, because to achieve the mucosal margin is possibly one of the easiest things. A lot of people, most of the people tend to get it right. But with regards to deep margins, I think that you'll have to really sort of spend some time not cold the sort of tissues. So it has to be as wide as possible. Go by palpation, and bony margins, as said, it has to be the clinical aspect will be slightly lesser. It will be there only when you'll have to do a marginal mandibulectomy or so. Only then the clinical assessment comes. But when the bone is clearly eroded, then I guess no, it's more of radiological assessment, and go about a centimeter and a half or more to achieve the clear margins. Sometimes when you do a marginal, you can sort of do some inference cytology.
Sorry for the sorry for the interruption. Actually, it's not very audible. Can you a bit more louder, sir? I know you're out, sir. Sorry.
Yes. I think I've made my points, Poonam. I think I'm outside. Sorry, so it may be difficult. I think made my points.
Right, sir. So I think great points. I think if you see the bone margin, again, your concept of the mucosa involved over the bone, then the bone erosion on the CT scan, the marrow involvement on the MRI, this all plays a very important role. And in fact, I was browsing and I was trying to search more papers on the bone margin, and I came across that there are not many papers to look for how should be the bone margin. I think this is a very good paper by Arjun from our team. And this has shown that if you have a good, I think more than one actually. So it is usually if you are around 15 mm of margin, you can achieve a clear bony margin in majority of the cases. So with this, we come to the same conclusion that at least a gross margin, and in bone, usually a 1 to 1.5 centimeter margin would be a good way to go ahead. Naturally, you have to see the mucosal involvement on the alveolus. You have to see the CT scan whenever needed. And in cases of marrow involvement, if possible, you can do the MR. So coming to the role of frozen section, I think we need to wrap up in another 5 minutes. So I will quickly go through this. So I think we all know that frozen section has been useful. It gives us a confidence as surgeons that, okay, our margins are free many a times, because we don't want to face the patient in the post-operative period with a positive margin. Definitely, it gives us a lot of help. And there has been a lot of studies which have shown that the concordance rates with frozen section and the histopathology is as upwards as 97%. So if you see this Ackerman paper, long back again, I think this is again in 1950s, 1959, and this shows that the overall accuracy of frozen section is upwards of 98%. So if we see that the frozen section, actually, this is another paper by Byers, again done long back, and they have shown that usually it helps the surgeons to achieve negative margins, and it usually helps them to, in their study, it was beneficial in preventing recurrences. That was an inference in up to 23% of the cases. So then coming to this question, because there are both for and against frozen section. So in your routine practice, Dr. Arjun, Dr. Pankaj, Arvind sir, do you recommend or you routinely use frozen section analysis? Why I'm asking this is that a lot of youngsters who are doing their private practices may not be having this frozen section facility. And what do you recommend to them?
Dr. Poonam, as an institutional policy, we always use a frozen section examination. The two things that I want to highlight, the first is the role of the surgeon when the pathologist is doing a grossing. So as a surgeon, we always go to the pathology room, tell the pathologist, because the oral cancer specimens or head and neck cancer specimens are usually complex. So it becomes difficult for the pathologist to understand them and orient them. So that thing is very, very important whenever we are sending a specimen for frozen section examination. Second thing is, in today's time, there could be a lot of legal issues also. So in order to prevent them, it is always better, and we do it as a practice, to always send a specimen for frozen section examination.
Right. Great points, Dr. Pankaj. Arvind sir, would you like to comment?
Yeah, I think it's a very complex topic in a paper. See, there is a distinction between what we practice in real world and what the evidence actually says. Of course, what is very clear is that you have to get your. I think generally you use the frozen section as an aid to achieve a margin in the section, and we discussed that it has to be more than 5 millimeters. So the best thing is that you sort of gross means resect it a priori upfront. Maybe if frozen section is not available, there is some evidence from Tata's itself to suggest that more than 7 millimeters may be a reasonable way to go. And as was pointed out by Pankaj also, I think because these specimens are complicated, take the specimens to the pathology and sort of if at all you're doing the frozen section, then you can sort of take it to them. Again, there was a Mustafa Bulbul's meta-analysis in 2019 that suggested that achieving upfront R0 is the best. If you achieve R1 and then subsequently revise it to achieve R0, it did not make any great dent in outcomes. And there was also another paper from Tata's about the cost-effective analysis also of frozen section, which suggested that a routine use of frozen sections may not be cost-effective. But again, you have more guidelines. Even the NCCN and some Latin American guidelines seem to suggest that you do sort of recommend the regular use of frozen section. So in my practice, what happens is we send it for regularly for frozen section. We send the specimen for frozen section. Just because it's available, and also as Pankaj said, we just want to know that everything is right. Of course, from the medical legal also to some extent that's what we said. But then I just want to say that if you don't really have a frozen section, also it doesn't mean that you cannot operate. Just go a little wider, maybe around 7 millimeters, or try to achieve 7 millimeters. So to achieve 7 millimeter of negative, then you have to go little more wider than a centimeter for that to achieve that 7 millimeter distance. So just be liberal, and then you should be good. I think.
Correct, sir.
I don't know. I hope I'm not confused you all more.
No, sir.
This is the dichotomy between the evidence and the real world practice.
Very clear point, sir. So I think for the surgeons, for the youngsters who don't have the facility, first I will come to that situation, the real life situation many times where you can't get a frozen section. It is good to have at least a minimum of 7 mm margin. This has been this study conducted at Tata Memorial Hospital by Pankaj Chaturvedi sir and Saurabh Datta. This is a very good study, and this shows that a minimum of 7 mm surgical margin usually awaits the need for the frozen section. Having said that, we need to know that frozen section can be great help in certain situations, like Dr. Pankaj rightly said, that head and neck anatomy is quite complex, and many a times nowadays with a lot of medical legal issues, like I said, it actually helps us a lot. Again, having said that, you have to know that frozen section itself has limitations. Like we already said, it needs a good institutional setting. Then this intraoperative cost can be there. Even for our own study, we saw that around 11,000 rupees have to be spent for each frozen section. Even we didn't know that. And that frozen sample analysis and sampling methodologies are not well standardized. It's not that they are same policies or same methods are used in every center. And one of the most important point is that even though we may be doing frozen section and we want to achieve negative margins, we may be incorrect several times because we are not well oriented. And one of the most important point I would like to say here, which Dr. Pankaj initially said, is that it is very important that if you really want to utilize the frozen section use, it is ideal that as a surgeon you interact with the pathologist, because for a pathologist the orientation of the tumor is entirely different as compared to a surgeon. So a close collaboration between a surgeon and the pathologist within the OT complex is very important to have a good discussion regarding the frozen section. So I just thought in this situation, if we are not doing routinely, usually I try to do it not for every case. I usually send it for ill-defined margins, PMDs, submucosal disease, perineural invasion. And when I see if I could save the skin, because they're not very sensitive method, CT or MRI to assess the skin. But I think this all is debatable, and we are already short of time. And I think we are conducting a study at TMH and ACTRAC, which is a randomized study comparing frozen section versus final HPR for the assessment of margins, and we'll have answer in 1 or 2 years. So this, I think, is going to be the last question. So I think, Arjun, would you like to comment that does revision of margins help in terms of loco-regional control and overall survival? Like, how should we go ahead? If a junior is going ahead, margin comes close or positive, what will you suggest them? That is going to be the, I think, second last question. One more question, we are going to wrap up.
So I think first shot is the best shot, madam. If you are going to be clear in the first shot, a lot of evidence is there that even if you revise after frozen section or your own assessment, based on that, you're going to revise. Your first shot is your best shot. This is intra-op. Now, sometimes what I'll just take it a step forward and say that, sometimes in the post-operative setting, in your final pathology report, you do find a close or a positive, rather a positive margin, not a close, but a positive margin. There, I think that's the dilemma where you're stuck with two situations. One, you may want to go back in and revise that close margin.
Sorry, Arjun, this is the next question for Shwetab, and this is the question for you. So do you revise your margins routinely? So whenever,
No, madam. So I don't use frozen section in all situations. If it's a clear-cut case, I would rely more on the clinico-radiological assessment that we have done and go ahead with the surgery. If I gross the specimen myself and see, if I feel that there is a margin close, for better or for worse, I will go in and revise. But there is a lot of evidence from Kerawala and Nang as well that you're only 1 out of 10 times you're going, or rather 3 out of 10 times you're going to be in the right place that you needed to revise. So with that said, if there's limited morbidity that I'm going to give, I will revise again. But if there's something major, I don't think I'll go ahead.
Yes. So any role of adjuncts you use, Arjun or Dr. Pankaj or Dr. Or molecular markers, anyone uses it routinely?
So again, okay, sorry, Dr. Pankaj, go ahead.
No, please go ahead. Please go ahead.
So these are all adjuncts to what you are doing today. So, you will need to first find the problem to use these adjuncts. So again, if your grossing is, you feel in your own assessment of grossing, you are, adequate or inadequate, I don't think adjunct is going to help you. What we do is we also ask our assistant and our colleagues to also gross. So maybe you as an inherent bias, because we are performing the surgery, sometimes we feel it's adequate, but just to negate that bias, probably a second observer or third observer consensus would be better.
So Dr. Pankaj, any like your comments on the post-NACT margins?
The first thing is we are not using any adjuncts, and we always send the sample for frozen section. And if the frozen section says the margins are less than 5 mm, we always revise it. Now coming to this post-NACT margins, I think that I answered you earlier. So that was really a controversial thing. So whether it should be a pre-NACT margins or it should be a post-NACT, and with such a good, excellent response to NACT, this is becoming really a very, very difficult situation to be in, because the response rates are so good. As I told you that in our series, almost 60 to 70% have excellent response, 20 to 30% have hardly, any tumor visible. So going the pre-NACT margins is very difficult. So we take wider margins, somewhere in between 1.5 centimeter margins we usually take in these situations.
Right. So I think there's no consensus. We have to go as per the post, as we have to assess the pre-NACT and the post-NACT disease. And we can go ahead. There is no consensus. I will not go in detail. So I think we know for positive margins, we all know CTRT is going to be this thing. But for this last question for you, Shwetab, so are you going to give for, if we know that close margin distance is not this one distance, it is a continuum. So it is ranging from 1 mm to 5 mm. So if your margin comes as one margin only, it is 2 mm. And the other, in other case, it comes as 4 mm. So will your philosophy change regarding the radiotherapy for the adjuvant? We can't revise the margin now.
Yeah. So, madam, I think in today's day and age, I think it is not only enough to quantify that the margin is closed. We have to quantify why the margin is closed, which margin is closed, whether it's a mucosal margin or deep margin, whether it was revised intraoperatively, frozen section at the same time, or it's like the case that Arjun mentioned that we got to know post-operatively and then we are looking at revision. So all those factors play a role. I don't think that simply now a 4 mm close margin or even a 3 mm close margin, just because it is a lateral mucosal margin and where we have looked to preserve the skin and the clinico-radiologically the buccinator was intact, is an indication in itself for adjuvant RT. We also have to look at the other adverse risk factor that we saw in the final histopathology report, whether there was a perineural spread, what was the worst pattern of invasion. There is some evidence to say that in the worst pattern of invasion 5, your margin should be wider. So in two margins, 2 mm, 4 mm, and if my surgeon is saying that this is not possible to revise and this was unplanned and everything, I would not deter in offering adjuvant RT to a higher dose. But it is definitely important to know why the margins were closed and which type of margin were closed.
Right. So I completely agree with you, Shweta. I think this comes in our day-to-day practice. And if only one margin is closed, and we, like you rightly said, anyways, we are using another modality. It is a moderately differentiated cancer, no other risk factors, and patient is going to come on routine margin. We cannot revise it. There is a possibility we can keep it under observation also, but that final decision has to be ultimately in the multidisciplinary clinic. So I think that would be my last slide. And with this, I will wrap up. I would request all of you to comment if you find something you are not agreeing to. So for your margins, 1 centimeter, 3-dimensional surgical margin is the way to go, which is the gross margin. And you should achieve at least a more than 5 mm pathological margin. Revise whenever a margin is positive specifically. Close margin ideally should be revised. It should be a specimen-driven margin, as the NCCN suggests. Again, we are saying in ideal situations. Frozen can be used if it is available. It has some cost available to it, but it does help the surgeon to gain the confidence. If not, if you have to use it judiciously, in those cases, you can use whenever you are suspecting it to be close or positive. Bone margin, usually go by your radiology, the clinical findings, and 15 millimeter margins gives you a good clear margins. Role of frozen section for cortical bone is not very conclusive, and marrow also is difficult. Adjuvant radiotherapy is must for positive margins. Role of adjuvant for closed margins, I think, can be discussed further. With this, if any comments by the panelists, I would request them to give. Otherwise, we would be concluding today's this discussion. Any comments? Arvind sir, Dr. Pankaj, the concluding comments, Dr. Arjun or Dr. Shweta?
No, I would just say, Dr. Poonam, very nicely summed up things, and we completely agree with whatever you have written.
Thank you so much. You have been kind. So with this, we would conclude today's this webinar, day 1. And I would request all of you to join us tomorrow at 9 o'clock in the morning. We would be going ahead with the discussions on the thyroid, larynx, and I think we have on parotid as well. So parathyroid, I'm sorry. Now hypoglycemia is setting in. So thank you so much. And with this, we conclude. Thank you so much to all the esteemed panelists. Thank you.
Thank you, madam.
Thank you. Thank you, Poonam.
Thank you so much. And the delegates, especially. Thank you so much.